Hey, good morning, everyone. My name is Jim Murphy. I'm the interim regional director for the Northeast Musculoskeletal Institute, and I want to welcome you all to the John M. Parenti Limb Preservation Annual Lectureship. You know, it's a kind of a rare occasion these digital times where we can all sit together, listen, learn, slow down, and maybe drink some coffee together. So it's a very special opportunity. I'm grateful for your company today. But we really owe this opportunity to the efforts of Dr. John Parenti and Dr. Arturo Porzakansky. You know, I was fortunate enough to be here at Geisinger and see Dr. Parenti interact with both patients and staff, so it's no surprise that his exemplary care of Dr. Porzakansky would leave such a mark on him and his family to establish this lectureship in his name. And the warmth and caring of both men is palpable within minutes of meeting them. So please take this opportunity as a moment to kind of slow down, chat with some colleagues, sit, listen, and maybe drink some coffee together. So welcome. I'm going to give that's kind of a brief overview. This is Dr. Parenti and Dr. Porzakansky and his wife. I'm going to give you a video to kind of give you there's Dr. Porzakansky. There's the video. We're going to let the video do the talking. One more time.
My name is Arturo Porzakansky, and this is my story. The story begins in November of 2005, during Thanksgiving week, when, unbeknown to the Geisinger ER and ICU physicians, and to me, I was admitted in a state of life-threatening hypovolemic shock because I was experiencing the first episode of a rare disease called systemic capillary leak syndrome, or SCLS, which features the transient separation of endothelial cells in the capillaries of the extremities, leading to the extravasation of most of one's plasma into surrounding tissues and muscle compartments. These episodic leaks of plasma do not necessarily cause permanent damage to arms and legs. The leaks cause compartment syndrome, especially when, in an understandable attempt to keep vital organs duly perfused, ER or ICU physicians engage in massive fluid resuscitation, which is what they did to me. Once we're properly diagnosed, ER and ICU physicians know that, should we experience an episode of SCLS, they ought to minimize the administration of fluids to prevent massive leaks and further muscle and nerve damage, while having orthopedics monitor our muscle compartments in case preventive surgery in the form of fasciotomies becomes necessary. Given the extent of the damage, the surgical team on duty was initially uniformly pessimistic about the chances of salvaging my lower legs, so they recommended their amputation. I was deemed too vulnerable to infection, accidental loss of circulation to the feet, and other complications and negative outcomes of limb salvage in the wake of so much destruction. They could not conceive that I would be left with functional legs and feet that I could use to walk on, whereas an amputation and modern prosthetics, like the carbon fiber blades that the South African runner Oscar Pistorius made famous, had proven to be effective in the restoration of almost normal function. The next thing that happened was that my family and I refused to grant consent for the amputations, especially on advice from my brother-in-law, then a senior Geisinger vascular surgeon. Because my episode of SCLS had concluded, my general clinical picture improved rapidly. Moreover, there were pulses in my feet indicating sufficient blood circulation to them, and I was relatively young and otherwise very healthy. There was thus no urgency to proceed with a preemptive amputation. The challenge, however, was to persuade at least one Geisinger surgeon to commit to the salvage and preservation of my limbs. Dr. John Parenti, at the time chief of orthopedics, then joined the team.
I had been on a vacation and was not here at the hospital for probably an entire week, but during that time, Arturo had been brought to Geisinger via life flight in serious condition and ended up in our ICU. When I first met him that Monday morning, though, that was in a regular clinic room since he had improved dramatically over the few days that he was here, and I was meeting him to discuss further surgery.
And to make a long story short, we succeeded in persuading him that I had a good chance of surviving the many operations that would be needed over several weeks to remove all necrotic tissues.
The uniqueness of this case is the fact that throughout his surgical procedures, numbering at least 6 and probably more, I had to remove every muscle from his lower extremity from his knee to his ankle. I had never done that previously, nor have I ever done that since.
To be sure, neither he nor us knew to what extent I would be able to walk again and go back to work, since no muscles or nerves survived below either knee, and both my feet were immobile and insensate. The most likely scenario was that I would end up in a wheelchair, so much so that I went shopping for a motorized scooter. But something told me not to buy it. I checked myself into an inpatient facility for several weeks and put a lot of effort into physical and occupational therapy, followed by still more weeks of outpatient rehabilitation following my return home.
I was amazingly surprised to see Arturo back on his feet when he first returned to our outpatient clinic. Having undergone such incredible surgeries, both in number and in extent, I really didn't think I would be seeing him walk into clinic. I was very surprised to see this. I definitely expected him to be in a wheelchair at that time, and he thoroughly surprised me. To this date, Arturo's feet have held up remarkably well. His extreme vigilance in taking care of his feet is remarkable. I've not noticed any breakdown of his skin, any calluses, any open wounds or ulcerations, despite the fact that he has no sensation in his feet, nor any movement at his ankles or toes.
My wife and I decided to endow the John Parenti Orthopedic Education Fund for 2 reasons. First, we wanted to recognize Dr. Parenti for his lifelong dedication to patients with challenging orthopedic and wound healing problems, and to pay homage to his personal courage in this specific instance, in which he took on and persevered with a high-risk case, demonstrating excellent surgical and post-surgical skills, and showing compassion for and confidence in his patient. And I'm referring to me, of course. Second, because we wanted to change the mindset of the orthopedic department by sponsoring a lectureship series that would bring renowned speakers from around the country to talk about the latest developments in the field of limb salvage and preservation.
We operate on patients, we don't operate on x-rays, we don't operate on lab results. We have to see the patient's needs and to listen to what they want if truly their decision is not totally so bizarre that it's not in their best interest. Arturo was an amazing patient. He was a healthy gentleman. He came here without comorbidities. It was safe to take him back to the operating room to do multiple operations. And thus, I feel the takeaway here is the fact that we were able to listen to his wish not to amputate. And then, even though it was time-consuming and maybe not most expedient, we took him back to the operating room and did numerous repeat debridement procedures over and over in order to salvage his extremities, which is what he wanted, and he's extremely pleased with this.
The fact is, surgeons usually don't have to deal with the serious physical, psychological, and financial consequences that follow from limb amputation. Therefore, what looks like a successful outcome to a surgeon is sometimes not viewed as a successful outcome by patients and their families. This is a perception gap we want to see closed.
I think that's such an inspiring story of resilience, and I think it's more a testament for everyone in the room. Everything we do matters. It matters to patients. It matters to their family. And sometimes it's always hard to remember that, but try to remember the purpose of that. It's just that what you do really matters. So at this point, I'd like to turn the meeting over to our conference chairman, Dr. Christopher Grandizio, who's our current chief of shoulder and elbow surgery in Musculoskeletal Institute and professor of orthopedic surgery at the Geisinger College of Medicine, and has put together a fantastic program. So, thank you.
Thank you. I have been tasked with providing a few housekeeping items for today. The first request is please silence cell phones in the lobby in the back if you need to make calls or answer messages. Restrooms at any point are also directly outside the doors in the lobby. There'll be multiple opportunities to ask questions. When you do so, please come up to the mics. The event is being live streamed, and that gives our colleagues who are not able to attend in person an opportunity to hear some of the questions. But thank you, Dr. Portacansi. As always, very much appreciate you being here and for your continued support. This is always an event that we look forward to, and we thank you again for being here. Same for our attendees. We appreciate you making the time to be here. I am really excited to be a part of this course today. I think we could spend an entire conference discussing Dr. Parenti's contribution to our department. He's had a profound impact on my career and our day-to-day lives at Geisinger. I know a lot of people in this audience, can say the same thing. He's our two-time chairman, and much like coach, that's a title that really never goes away. And you may or may not have heard, but there could be an opportunity for a round three. I'll just leave that there. We have a fantastic lineup of speakers today, and it's my honor to get to introduce both of our guest lecturers today, both of whom are from NYU. Our keynote talk today will be from Dr. Omri Aylan. He's an assistant professor at NYU and the co-director for the Center of Amputation Reconstruction. In addition, he's the associate fellowship director for the hand surgery program at NYU. I've been really fortunate to get to know Omri over the last few years with some of our work at the ASSH. He's a tremendous educator, a fantastic surgeon, and a really dynamic speaker. And I'm really excited to have him be a part of this, and appreciate both of your efforts in being here today. So without further ado, I will turn this over to Dr. Aylan, and we'll begin. All right.
Thank you so much. Can everyone hear me okay? Is this coming through? I've never been told to speak louder. So first of all, I just wanted to thank everyone here at Geisinger for having me, and Dr. Agarwal. It's a real honor to be part of this tradition. And I've looked back at prior years, and it's really impressive, sort of the topics and the challenges that are tackled here. I'm definitely open to suggestions for disclosures if anyone has any. So just a little bit about my preparation for coming here, and just being sort of inundated with the feelings of gratitude towards both of you and Nina as well. And just from the short time that I've been here, it's really inspirational, Dr. Parenti, to see the impact you've had on not only your patients, but the countless trainees here and people who have worked under you. And so as a leader and as an educator, I am definitely taking notes and hope to follow in your footsteps. And Arturo and Nina, you guys have been gracious hosts. I've had dinner last night, and I felt like I was at home. They're offering me food from their meals and everything. So thank you very much for everything you've done. And what you've been through medically is also actually pertinent to what we're going to be talking about today. So, and then just as a health system, it's very evident that you guys are doing it the right way with education and focusing on the important things. I had the pleasure of sitting down with Joel last night, and I can see that your leadership in the residency and also in your clinical work is something that I also am striving to emulate. So, and then one last thing. I swear I'm going to actually give a talk. But Dr. Grandizio, just like you said, thank you for everything you do, and you're definitely a role model to me in clinical research, training. So thank you for inviting us. Okay. So something we talked about last night with Dr. Parenti was how the focus on amputation has changed and how the management of amputations have changed over his career. And hopefully I can sort of build on that and give a little bit of perspective. And so individuals who have limb loss or amputees, these are some of the things you have to think about when you're taking care of them. Every case is different. As we saw with Dr. Porzakansky, an amputation is not right for everyone, and every situation dictates specialization. There's issues of limb length. You have to make sure your patient is nutritionally optimized. You have to think about the goal of the prosthesis before you do the surgery. You have to make sure that they don't have pain when they're using one. And so there's some little tidbits about soft tissue management that I'm gonna go through today. So when we think about upper extremity amputations and prostheses, we think of like the Bionic Man and all the crazy stuff that can happen in science fiction movies, when in reality, the technology is amazing, and I'm gonna go through it, but this is the real world. This is a patient who's first getting his first myoelectric prosthesis, and he's focusing on some daily tasks. And so I think with the excitement of this like really cool field, you have to also temper expectations with your reality. Some more sort of Debbie Downer moments here. However, it's important to know that individuals who are experiencing major limb loss, the mental health aspect is extremely important. It affects not only their lives, it affects their families' lives. And it's something that you have to take into account and treat very carefully. A majority of these people experience pain, phantom limb sensation. Phantom limb sensation and phantom limb pain are different. And this is sort of, this stat here is kind of what I'm focusing my career on. Prosthetic abandonment. You give a patient a prosthesis for their upper extremity, costs $75,000, all the bells and whistles, and it ends up being a paperweight in their closet. And so how can we be better? Our surgeries have to be better. We have to be better at taking care of people so they can actually use these things. I can show you pictures until the cows come home of these awesome prostheses. This gentleman on the left is in his early 20s and has pretty much state-of-the-art prosthesis, myoelectric, TMR plexus, and he can bend the elbow, he can open and close, and that's about it. And so we'll come back to his case later. As opposed to the gentleman on the right, who has a body-powered prosthesis that uses it a lot more. So you have to know where you're going to get there. So let's get to work. So a little touch on terminology. We talk about limb salvage, and what sometimes we lose sight of is that oftentimes an amputation is not a failure. And sometimes amputation can be salvage for certain patients. And so even the terminology that we use, that limb salvage, just keeping the limb, Dr. Porzakansky's case aside, because that's an amazing, amazing result. But sometimes an amputation can help an individual. And so if you know what some of the problems are, an ounce of prevention, obviously, however that saying goes. Okay, so there has been a rise in amputee interest and care, and I think part of the reasons have been, if we're being honest, is reimbursement initially has not caught up with the reality or the volume that's happening. And so we'll talk about that as it pertains specifically to nerve surgeries. And in general, what's happening in this field is that the engineers and the nerds, which is, we love the nerds, but they're developing these awesome technologies, and our surgeries have not caught up to be able to interface with them. And so as a result, we have these cool things that we can't actually use in real life. Okay, so what are some of the challenges that these folks experience? They don't use the prosthesis. They can't put it on and take it off. That's called donning and doffing for the residents. It's painful to wear. It's hard to keep them attached because for an upper extremity, you're talking about a suspensory prosthetic as opposed to a lower limb that you're obviously bearing weight. How do you control a terminal device with myoelectric or body powered? And then talking about costs. The average major limb amputee, BKA, AKA, transradial, transhumeral, on average needs a new socket every 6 months. And those are extremely, extremely expensive. And so we'll touch on that. And then, of course, something we don't talk about is a prosthesis. Prosthesis is not sensate. If you don't have sensation, you don't have function. And so we'll talk about how to optimize some of these things. So basically what we did at NYU is we decided to create this multidisciplinary model where we put the patient at the center, and our whole team evaluates and takes care of the patient together. So our team consists of OTs, PTs, mental health specialists, surgeons, and prosthetists. And so we evaluate them together from day one, and we have a plan, and the prosthetist's input is just as important as my input as the surgeon. And oftentimes, their input can dictate what happens in the surgery. So you must know the prosthetic options if you're going to do these surgeries. And in our training, we don't typically learn about prostheses. You know, when I was a resident or a fellow, I never once learned about, you know, the difference between silicone versus static progressive splinting for digit reconstruction. So we'll go over some of that stuff as well. Making sure that patient goals match actual outcomes, I think, is also super important. So the patient on the left may have very different expectations or needs than the patient on the right, who has basically a congenital AVM affecting her whole upper extremity with severe pain. A touch about joint length, and I'm not going to go in crazy detail, but something that I've learned from my prosthetic colleagues, you know, when we're trained as orthopedics, we generally think longer is better. We try to preserve length. For prostheses, it's almost the exact opposite, because you have to create room for the joint that you're reconstructing. Now, sometimes you can leave a patient with a helper limb, like a wrist disarticulation is probably the worst level for a prosthetist to work with, but for a patient who doesn't want to use a prosthesis, that's a longer limb to use as a helper hand. So you got to talk to your patient, you have to understand their needs. This is just showing the joint line of an elbow, that this prosthesis, obviously this limb was left too long, and so that patient has a lot of trouble because their arms are so asymmetrical. Okay, so soft tissue management, this is on us. This is the biggest issue I see with major limb amputations and inability to use a prosthesis. It's simply leaving too much soft tissue and not anchoring the soft tissue to the fascia. I mean, that's it, nothing crazy. And you get this redundant tissue, and you can imagine that person trying to wear a prosthesis either to walk or on their arm and just slip sliding around. I love this picture on the left, on the bottom right. I call this the finger popsicle, or lollipop rather. It basically, this patient had a groin flap to preserve a little bulk, but you can't really use that. It's not, you can't put a prosthesis on there. It's asensate. So this sort of didn't help the patient at all. Okay, so nerve management is a very big issue, and when you're taking care of these individuals, you're trying to prevent neuroma pain, you're trying to prevent pain when they're using a prosthesis, and you're trying to prevent phantom limb sensation. So one of the techniques we use that I'm sure you guys know about is TMR, targeted muscle reinnervation, which is basically closing a circuit. When a limb is amputated, the nerves are just sort of left in the soft tissue to cause pain and further dysfunction. And so essentially, you're just closing the circuit. You're attaching the amputated, usually mixed motor nerve to a motor target that's innervating a muscle. And in general, it's been transformative for a lot of people. And so how we use it in our institution is this starts before surgery if you can get to it. And we do a lot of diagnostic injections with lidocaine. So I'll go up to the radiology suite with one of our radiologists with the patient. I'll examine the patient before, mark out the neuromas, try to really cause them a lot of pain. And then under ultrasound, we'll numb up the nerves with lidocaine, re-examine them, and that should hopefully give us a little bit of an idea if a peripheral nerve surgery will help. Because with these folks, they've had these circuits for sometimes so long that even fixing the peripheral problem, the pain has become centralized and it doesn't help them. So this has bailed me out in avoiding a big unnecessary surgery for patients. So for every surgery, you have plan A, plan B, plan C. This is like the transhumeral level, the most standard TMR transfers. And if it's not so important, the specifics, but if you understand, the principles, then I think TMR can become a very important and powerful tool. One of the reasons we do it is to increase the number of sites that can power a myoelectric prosthesis. So if you have an amputation through the humerus, you really only have biceps, brachialis, and triceps to work with. So TMR can increase the number of sites. So what that means is a prosthesis can, instead of just elbow flexion, elbow extension, and then they hit a switch to then open and close, you can then have all that simultaneously. So, and now the median nerve is intuitively working to close their prosthetic hand. And the radial nerve is now opening, so it can really increase your options there. This is a patient who, this is the first time we're myotesting him after an amputation. I don't know if you can see, but on the computer screen, he's figuring out how to control a digital prosthesis. This is like his first time, and it's so intuitive that there's very little training that needs to happen. And I'm sort of building up here, but like TMR is great, but there's also some downsides to it. Anytime you cut a nerve, they're gonna have pain. You're creating a nerve issue. So you have to tell the patients that. And then as that coaptation heals, then the nerve pain starts to go away. So from just a technical standpoint, if you guys are doing these cases, when I first started doing them, I didn't listen to this advice, but you should find your motor targets first when you're using a tourniquet, because you'll lose the signal and then you're sort of out of luck. You gotta let everything revascularize. When you do these transfers, try to do them close to the muscle so it decreases the time of reinnervation. This is just my poor attempt at a diagram on PowerPoint to show how we do these coaptations. But essentially, you can see the size differential between a mixed motor nerve and a motor target. And we'll talk about ways to mitigate that. So this is kind of like what it would look like. And usually we invaginate it in some nearby muscle to prevent axonal sprouting. And then typically we kind of do this combination of RPNI and TMR, which just helps prevent creating painful neuromas. So let's talk, brass tacks here. So in every nerve transfer you do, the recovery is not 100%. We are, by definition, creating a neuroma, which can cause pain. You're not replacing like with like, meaning a mixed motor nerve has motor and sensory, and you're trying to get just motor response. Unmasking is the bane of my existence. You take care of one problem, you create another one. And so it's like at the county fair, when you're playing whack-a-mole, you keep hitting them and they keep popping up. So that's why you have to really plan for these surgeries and try to take care of every possible issue. So is it enough? I think the answer is yes. However, these are the biomechanical pathways that happen when you cut a nerve. So obviously, you start to get apoptosis, the muscle fibers shrink, okay? And then you do this nerve transfer that's very cool, and you're juicing up that muscle. But the problem is that innervation is only happening at the point that the motor nerve goes in. So what's happening to the rest of the muscle is muscle death. And so when you're doing TMR, by definition, you will weaken that muscle. And sometimes that's okay if you're only trying to get a signal. But if you're worried about muscle bulk, then TMR may not be the right option. So there are some things to think about. And then moving on here, knowing some of the prosthetic options, for some patients, just restoring, the silicone likeness of their hand. And there are artists who do this, which are very remarkable. And sometimes you don't even notice that they're wearing a prosthesis sometimes. This is a patient of ours who is a sculptor, and he uses these simple body-powered digit prostheses, and he's able to work remarkably well with very fine motor tasks. So there are some gory pictures here. I hope that's okay for everyone. The residents, if it's not, then you should probably look into something else. So I wanted to touch on just like tidbits about each level in the upper extremity, and just to maybe get your juices flowing, thinking about other options. So if you see, a patient like this, there are some reconstructive options. You take a toe. There are other options that I'm really fighting hard not to pimp the audience, the residents. But So, you have x-rays like this, you have a CMC joint there that you can use that is sort of the big delineator here. And so something that we opted to use was no prosthesis and to turn the index finger into a thumb that we do a lot in the pediatric population, but in this traumatic adult population, basically you're just rerouting the muscles and the tendons, and you're taking a wonderful finger, the index finger, and turning that into a thumb. It's sensate, it's strong, and you end up with this hand that, it definitely looks different than it did before, but it's very functional, and hopefully you can kind of have a patient who's happy with her function. Now, moving up the ladder a little bit, you'll see patients who have transmetacarpal amputations. The main issues here generally are painful neuromas because you're cutting those nerves right at the common digital nerve, right in the middle of the palm. And so that's generally what's going on. And then as hand surgeons, we're very comfortable around the ulnar nerve in the hand, Guillen's canal, hook of hamate fractures, we're kind of used to that. And so if you just do that same approach and you know where the interossei are being innervated, and that's these arrows here, then you can do a simple nerve transfer, meaning TMR in the palm, and you can take care of painful neuromas. Another option at this level is called the starfish. Has anyone heard of the starfish procedure? Have you guys heard of it? There you go, we got one, nice. So the starfish procedure is basically an attempt to power a prosthesis in the hand. And the problem with the prostheses are you have to sense the muscle firing, but the muscles in the hand are too deep. And so what this surgery does, very simply, is you take the interossei muscle and you just transfer them on the back, on the dorsum of the metacarpal, so they're subcutaneous, and then it can sense the myoelectric signal that's happening from the muscle. So this is a gentleman who basically, this is his first time after a starfish procedure, and it's just showing how some of the stuff he can do very intuitively and even get individual digital control. All right, so the next picture was one of our patients after COVID who had pressure-induced necrosis. And when you guys do a transradial amputation, usually we throw away the pronator, quadratus. And what I want to tell you is save it. All you have to do is elevate it off the muscles and the interosseous membrane. You have a vascularized, innervated flap that you can use to power a signal. And if you just suture it to the end of your residual limb, they can now use a prosthesis to rotate the forearm. And so that one little muscle can increase 1 degree of freedom for a patient. That's a huge deal. Because if you're stuck in neutral your whole life, that's much different than being able to rotate. So this is just elevating that little flap. I'd like to say that it's fancy surgery, but if I can do it, anyone here can do it. And so basically, this is just showing some basic amputation principles of a myodesis. And at the end, you should have a firm, stable residual limb here. And the TMR is sort of less important for this part, and the RPNI. But I generally do RPNI for the smaller sensory branches and TMR for the larger mixed motor. And then at the end, you should have a narrowed, bulleted shape of a residual limb. You don't want to have a limb that's too bulky, so the prosthesis can fit nice and snug. And then moving up the chain here, for the transhumeral level, something that we deal with a lot is just excess redundant soft tissue and skin. And so as orthopedic surgeons, we don't really think about body contouring or brachioplasties. However, I think it's essential that as orthopedic surgeons, we know about this because we can really improve the outcomes for these individuals. And so this is just some pictures showing some of the large brachioplasties that we perform, and they are not hard. Now, how do you manage the bone? So if you think of the humerus is a very thin cylindrical bone. And if you're trying to suspend a prosthesis, you need a way for it to anchor. You can do that with harnessing across the arm. You can use intense suction. But if the humerus has a little bend to it, or you preserve the condyles, then a prosthetist can suspend a prosthesis from those. So two of the options that we do is we shorten the humerus quite a bit. or we do a flexion osteotomy. And here's just a video kind of showing the flexion osteotomy. And it's just good AO principles. You take a wedge osteotomy, you flex the residual humerus, and then you just put a plate and you bend it and put a lag screw or two. And it makes a huge difference so that then they can have rotational control of their prosthesis. And it doesn't really add a whole heck of a lot of time to the procedure. You kind of get the idea. I don't need to go, show me putting in plates and screws. After you have the bone managed, you really want to take your time doing a nice myodesis. And these are the steps that I think are often skipped and maybe just not focused on enough. A firm myodesis can have a huge impact on the patient's quality and ability to actually use a prosthesis, trying to cut down that prosthetic abandonment number that we were talking about. So for the nerves at a transhumeral level, I kind of talked about it already, but essentially you're basically trying to divide the triceps to get another signal for the radial nerve. The median nerve, generally we use the short head of the biceps. And for the ulnar nerve, we generally use the brachialis. The problem with the ulnar nerve is it does seem to be more temperamental than the other nerves in transfers, but typically the brachialis does work pretty well. Here's just a case example of that patient with the large AVM, and we just did a good old-fashioned osteotomy, myodesis, nice closure, and she was able to actually use her prosthesis. She's back teaching in her elementary school. So now I wanted to end kind of by talking about the concept of bone-anchored prostheses or osseointegration that I think is becoming transformative for especially upper extremity, but we do a lot of lower extremity cases as well. So some of the issues we talked about, suspension, control, can really be improved with OI. So it's basically a way to attach a prosthesis directly to your bone to allow patients to bear weight. So if you're wearing a prosthesis, let's say on your leg, and you bear weight, that weight is not being transmitted to the skeleton. It's being transmitted to your skin, then your muscle, and then maybe a little bit of bone. For an individual, let's say, who has a high transfemoral amputation, often they're walking on their ischium because of the socket that needs to contain the limb. So here's a study just showing that OI for the upper extremity actually increases the number of hours that people use their prostheses per day and even the number of days per week. Taking a prosthesis on and taking it off I wish I had put another patient putting a traditional socket on, but on average it can take 12 to 13 minutes to put a transhumeral socket on. So if you are taking it on and taking it off twice a day, that's an hour. This is seconds. And so just that alone, the ease of putting it on and taking it off, can have a huge impact. Now, if you multiply that by individuals who have multiple limb amputations, most of your day is just putting on your limbs and taking them off. And so this can have a huge impact. Patients who wear sockets, they get sweaty, they have pain from pressure sores from a socket, and so there's no socket in OI, and they can do sort of impressive weightlifting that now makes me feel bad about myself looking at this guy. Now, another thing about the harnessing, it almost eliminates harnessing. Now, sometimes you need harnessing if they're like this gentleman, the gentleman on the right, who's one of our patients. He's also a plexus patient, and so his myocytes are limited, and so he does have to use a body-powered prosthesis to activate elbow flexion. But we basically finished his case in time for him to walk down the aisle. He wanted to have two arms for his wedding. We talked about that. And then something I wanted to touch on is one of the knocks that we get about OI is, well, it's so expensive up front. And that's true. However, so this study showed that actually lifetime OI results in a decreased cost of care because of all those frequent socket changes that we talked about. That issue is eliminated. So this is a bigger cost up front for the surgery for cost savings long term. And so we're trying to track that to make these cases more widespread. It's not all sunshines and roses. It's a lot of hard work. Most of this gray hair is from, doing peer-to-peers with people trying to explain what OI is and stuff. So in the US, most of the experience started in the military at Walter Reed. However, it's been going on in Europe. The longest integrated prosthesis right now is 32 years for an above-knee patient in Sweden. Also, not every institution has experience enough to do it, and so that's what, the more we talk about it, the more places are going to be doing it, which I think is great. And as long as it's being done at a high level, I really foresee this area taking off in the next 5 years. The FDA has been slow to adopt, but we've kind of gotten over the roadblocks now. That now we're able to get these surgeries approved by insurance companies so that patients are not left with a big bill. And then, of course, there's lots of things we have to deal with. There's metal sticking out of my skin. Doesn't it get infected? And so we have to, and we'll talk about ways that we mitigate. Okay, so some of the indications. Obviously, if you can't use a socket, I think this is a good option. If your limb is so short that you can't fit a regular socket on there, this makes sense. There's a lot of applications for neurogenic issues or soft tissue, and especially like we talked about, multiple limb involvement, which I'll show you later. So you have to think about how much do you have to work with, and I think the picture on the left is a lot easier to manage than the one on the right. There are some options for the one on the right. However, you can imagine there's no deltoid insertion. Your rotator cuff is probably okay, so that will impact the function of this person. Same thing, soft tissue needs to be debulked as much as possible. And there's lots of different implants on the market right now. I use a screw mechanism, and the reason as opposed to an impacted one, the reason is for the upper extremity, because it's suspensory, I want to have as much fixation to prevent that prosthesis from falling off. And so there are some other implants out there with various techniques, and the whole idea here is you want to load the bone. For the lower limb, we do mostly 2-stage procedures, and the reason for that is to get a skin graft to heal to the aperture site so that you don't have any infection. We don't accept any drainage. And of course, to do these cases, you have to have a team that's trained and ready to go to monitor and help these patients, for the rest of their lives. So the beginning of the surgery is just a simple exposure. You do an osteotomy. You're cutting the bone. And then this first part is just kind of like fun orthopedics. You're reaming by hand. You're tapping, you put this implant in, high-fiving. And then you start to get a little bit more dainty, and that's where the hand surgery part comes in. And we do the nerve management. Then after your implant's in, what you're doing is you're creating a muscle platform around the bone. Now this is sort of different than what we're trained. We typically don't want to leave bone exposed, but in this case, you want exposed bone so that you have a nice soft tissue envelope for the skin to heal. And so what you're doing here is you can see the aperture, the abutment, that's that metal connector that's sticking out. And what we do is we just thin the dermis so it turns into a skin graft. And we want to get that skin graft to heal to the humerus or the tibia or the femur or whatever we're doing. And you basically use a skin punch biopsy, and you have the abutment sticking through the skin. So is this a bone surgery or is this a soft tissue surgery? We feel that this is mostly a soft tissue surgery for it to be successful. The implant is like the easy, fun part, but it's the soft tissue that really matters. And that's what allows you to have a good outcome versus not. Sometimes patients require skin grafting if their soft tissue envelope was not good. So at the end of the case, you have something that looks like this. You have muscle platform ending proximal to the end of the bone. And then after the surgery, you have the metal abutment going through the skin. We treat it like a skin graft. We use a bolster dressing just to make sure that heals to the end of the bone. And then the patients are educated on how to keep this clean for their lifetime. So they do what we call flossing. So I'm just showing you here. They do this after their shower once a day for the rest of their life. And this just keeps that aperture clean and prevents infection. So now the fun part. So how do you then rehab from these? The nice thing is you can now load weight on your skeleton. And you guys know Wolff's Law is the only way bone increases in density other than from medications is actually seeing load, Wolff's Law. And so this allows you, OI allows you to actually load the skeleton directly. Initially after surgery, couch potato, Netflix and chill until that skin graft heals. And then you really start the work of gradually loading. And it's not that you tell them to do planks and push-ups from day one. They have to start very, very slowly. We give them a scale, and we tell them to put about 10 pounds, and then every week you go up by 10 pounds, and it keeps going until they're able to support the prosthesis. And then finally, they're able to do fun stuff like weights and rotational type work. This is just our protocol. And when patients are recovering from this, we tell them they have to be very attuned with what's happening with their pain. We want them to live in the green, and if they're a 6 or above, then I get a call right away. If they're in that middle phase, they just go down one step, and then they start over again. So in terms of outcomes, we're now catching up with our literature about the long-term outcomes. But the initial study showed 80% implant survival. The problem is that the one patient who had it explanted was sort of not complying with the regimen, which is okay. But the interesting thing about that individual is he elected to be reimplanted. And so that tells you that the impact that OI can have for upper extremity amputees is so large that even if something bad happens, which thankfully right now is about 5% implant removal, 5%, that those patients still request to be reimplanted. And so now we have more studies that show, no really implant removals for infection, and just the range of motion and functional improvement, you just can't compare. People are able to actually use their shoulder or their hip or their knee. And like I said, wearing and using their prosthesis more than before. So here are just some of our patients just kind of showing what it looks like in the recovery phase. On the left, you start with wall planks, and then you just gradually go to table planks, and then on your knees, and then on your hands. And this is just showing how quick and intuitive it is to just put this thing on. This patient is funny. He sometimes messes with us and puts his prosthesis on facing backwards. And it always gets a kick out of that for my fellows. And then you can see this gentleman on the right is now being fit for the first time for his myoelectric sleeve. And so when it's done, he'll just have a little neoprene sleeve around his arm that will have his electrodes that will be able to power his terminal device. And then we're just about done here. And then another exciting application of OI is for the thumb and for fingers and the digits. So for this patient, same thing. There are options of toe transfer, web space deepening, metacarpal lengthening, and checking out like a normal typical prosthesis for a patient like this would require something like this, a big glove, being able to have maybe a ratcheting type thumb. But this is pretty cumbersome. Imagine wearing that in 100-degree heat. And so this person had preserved thenars, so they have excellent function. And so we did OI for this individual. And here you can see the abutment, this cute little OI abutment sticking out, that now he's able to wear a prosthesis. And he also has a ring finger that uses just a regular body-powered MP flexion driver device. So this is what it kind of looks like before you put the prosthesis on. And this is just a quick video of showing how fast it is to take it on and take it off. And it's just a little Allen key. They put it in their back pocket, and they just can take their thumb off, take a shower, whatever they want to do, and throw it back on. So where are we headed? I think the reality is we're like 10 years away from widespread use of stuff like this. But being able to implant the electrodes in the body and the peripheral nerve is the next step for these, which will allow us to have sensate prostheses, and we'll be able to have more intuitive control for individual finger motion for these folks. And in summary, I want to leave you guys with thinking about amputation can be a salvage procedure. This is a patient of ours who's a 4-limb amputee, above knee, above elbow, bilateral, OI lower extremities, and we just finished her upper extremity OI, and now she's back traveling with her husband. She lives in New York City, and she's enjoying the city, and I sort of have to drag her in every 6 months just to check on her, but she's like, just leave me alone. And the other thing I would just leave you with is try to talk to people who live this life, the patients, the prosthetists, the OTs. They see more of these patients than we do as surgeons, and you can learn a lot from them. And of course, every patient is different, every person is different, and just keep pushing the envelope with what you can provide for these people so they don't have to be defined by their limb difference, and they can just live normal lives like you and me. And then finally, we have to close the gap between us as providers and the people who make the rules and the laws and the reimbursement so that that doesn't become a barrier to actually providing this affordable care for people. This is a patient of ours, Tracy, who had real trouble with a lower extremity amputation. And she told me before surgery that she dared me that if she does well, that she wants to do a polar plunge with me in February. And so this past February, it was 23 degrees outside at Rockaway Beach, and we went for a dip in the ocean. She was fine. By the way, she had a wetsuit on, and I didn't, so kind of unfair. But anyway, thank you guys for your attention, and I look forward to the rest of the talks. Thank you.
That was fantastic. Thank you. Thank you. I know there's a few questions, but I have one just to start us off. And I mean, it's very clear that you are at the cutting edge of some procedures and techniques that are still being developed and increasingly popularized. And you kind of alluded to the fact that in some of your training, especially early on, like these things weren't there. And I know you're really involved in education and working with trainees, and I think applicable that a lot of our audience are in a similar boat. This is a broad question, but how did you, at the start of this, kind of go about learning new techniques and kind of getting this like after your training? Because I think that's a question that comes up, a lot, is that some of these fields change so rapidly, and how do you incorporate new information in your practice? Do you have a comment maybe a little bit on what that process, looks like for you?
Yeah, that's a good question. I think oftentimes as surgeons, we're supposed to have the answers all the time. And I think for me, I just was okay saying, hey, I don't know anything about this, and being okay putting your ego aside and asking people about their experience. So I talked to prosthetists all the time. I still do. I went and spent time with them in their offices to learn how do you fit a patient for a prosthesis, because if you just put your ego aside for a moment, which is hard for us surgeons, I mean, I'm wearing a bow tie for God's sakes, that you can then kind of like actually learn, and talking to OTs, I learned so much from OTs about what it's like to actually do desensitization exercises. As hand surgeons, as orthopedic surgeons, you just write the script, you send them off, you never really see them again. But if you actually talk to them, how do you do it? You're using an actual Brillo pad to rub the skin at the site of the nerve transfer, mirror therapy. So it's important to just like dive in, put your ego aside, and just try to learn as much as possible. And I do hope that we can change the education a little bit so we include amputation care more in residency and fellowship for sure.
Great. Other questions, just please remember to use the mics so that our online audience can participate as well. But, sure, go ahead.
Can you hear me? I don't know if this thing goes any higher, but I'm freakishly tall.
You gotta hold a squat.
I can't do that for too long. It's too many years of residency. But, so my question is, we see a lot of these. I've seen several of these people come in with traumatic limb amputations and sort of like traumatic injuries that necessitate an amputation. And my question to you is, how do we set ourselves up for success at the next surgery for somebody like you that's going to do, TMR and stuff like that? In the initial stage, how do we set ourselves up for success?
That's a great question. And I don't want you to leave this talk with thinking that it can only be done at these highly specialized centers. These are techniques that can be done by any well-trained orthopedic surgeon, hand surgeon. But in general, when you're taking care of either a polytrauma or a severely injured limb, and amputation is the understanding from the start, the first step begins with discussion with the patient, making sure that they understand the implications, making sure they understand when we're done, you're going to wake up without an arm. And it sounds silly to say, but you have to start that process of connecting the patient with their new situation. You also have to have some idea of the prosthetic options. And so if you're doing, especially like, for example, the first thing I think about is limb length. And so if you, in the trauma setting, you want to get out of the zone of injury, you want to make sure that your ends of your residual femur, humerus, both bones are beveled. You don't want any sharp edges. When you close your myodesis, make it firm. You should not be able to wiggle the end of the limb. When you're closing your skin, close the dermis to the fascia so that the skin doesn't move. And then, of course, the nerve side of stuff also depends on your comfort, but RP&I, when done well, it takes 5 minutes. You take a piece of muscle, skeletal muscle, you use a 6-0 Prolene, you make a little taco, you suture it to the epineurium. You don't even really need loops if it's a mixed motor nerve. I mean, I would rather you have loops, but I mean, I need loops to eat breakfast. But even just doing RP&I and then documenting your note, we did RP&I for the saphenous nerve at this level. We did RP&I, and then at least then we know where the nerves are, what you did, and then if that becomes a problem, then it really simplifies things in the future. So having an eye for the fact that they are going to, like when we're on call and there's 100 cases backed up, I got an amputation, we got to get in there and just get it done. Take a second and think, this person is going to be using a prosthesis. Connect that future to what's happening right now, and then you can start understanding how to manage that limb. Yeah.
Great, and it's really great for our residents. You know, this is outside of our norm. So, and thank you for making me doubt that I've done anything positive in my entire career.
Oh my God, no.
You know, we had a pilot program about 15 years ago that plugged every traumatic upper extremity injury for a psychiatric, consult. Can you talk a little bit about that? You know, what goes into patient selection? I know you just alluded to it a little bit, and how many candidates do you reject? Based on that initial consult that you had with them, and how long is that process? How do you set yourself up to be successful?
That's a great question. That's a very nuanced question. Thank you. I would say that the mental health aspect is probably the thing that we ignore the most as surgeons in general, and this sort of aspect of my career has really opened my eyes to that, because you can't put someone through a big reconstructive surgery like this if you know that their psychosocial situation is not under control. So the first thing is just being aware that the femur or the humerus is connected to a person that has like emotion and feeling and family and stuff like that. So I don't know if you guys knew that, but patients actually have feelings. And then I think you have to have someone on your team or someone you have access to help you. For us, we have a social worker who helps us at least understand, like, you know what, this patient's family situation is not stable right now to undergo OI. Let's get him stable with a revision and get him into a socket, let him mature, get these issues under control, because these patients have been through trauma. And so pretty much uniformly, they're dealing with anxiety, depression, PTSD for sure. And then you're talking about these big surgeries. And so to answer your other question about how many do we turn away, we turn away much more than we do. That's just the reality. This OI is not for everybody, nor should it be, because it's not just the surgery. That is a lifelong decision. That's like entering a marriage. Like we have these patients for life. We want to keep close contact with them. They have to understand how to take care of it. And if you're talking about optimizing your outcome, the surgeon's expectations and the patient and the family's expectations have to meet. And the psychosocial aspect, it sounds hokey, but it's just as important as the surgery that we're doing. And I think being able to first be aware of that, and then having someone who's smarter than us to be able to actually document it and understand that. So for us, it's a social worker. Yeah. Thank you guys for your attention.
All right. Our next speaker today is Dr. Nikhil Agarwal. He is also from NYU. He did a plastic surgery residency at Baylor, went on to complete his fellowship in hand surgery at Mass General. He's an assistant professor currently at NYU and specializes in both nerve repair and microvascular reconstruction. And again, I really want to thank you for being here to join us today. So we'll continue with our next talk.
And again, I'll echo everything Omri said. Thank you guys for having me. Thank you, Dr. Parenti. Thank you, Dr. Brzezinski, for putting on this. This is an awesome event. Really appreciate it. Appreciate dinner last night. We had a lot of fun with you guys, looking around Scranton. So I'm from Ohio, so I like being a little bit closer to home. It feels a little bit closer to home than New York City sometimes. So we're going to switch gears a little bit here. We're going to talk about upper extremity limb salvage. Not something we talk about a lot. Actually, when I was trying to look into how to put this talk together, there isn't a great framework for it. I think we talk about lower extremity limb salvage quite a lot, but upper extremities, it's just a little more nebulous. And so what we're going to try to accomplish today is providing a framework for how we should think about upper extremity limb salvage. I think we have it established for lower extremity in a lot of ways. Obviously, things are kind of evolving, but we're going to separate limb salvage into acute phase, a subacute phase, and a chronic phase based on when those patients come in. And we'll talk a little bit about an algorithm for subacute limb salvage. And I think one of the main questions we want to try to answer today is, when is a limb worth salvaging, okay? And upper extremities, totally different beast than a lower extremity. The functionality is totally different. The prosthetics for the lower extremity can recreate the functional lower extremity okay. I think upper extremity prosthetics are obviously constantly evolving. But it's much more challenging innately. And I think most of us can agree when we're talking about the upper extremity, if somebody has a limb that they're not using, it's constantly in pain, and they can't feel it, so they're getting wounds, you've already failed at the limb salvage. The limb has not been salvaged. And so that, in those cases, when we talk about amputation being a form of limb salvage, that's probably what we're talking about. And because the prosthetics are getting better, we have to get better at limb salvage. So we have to be able to create functional limbs. We're almost competing against engineers in some ways. A lot of these prosthetics, the technology is just flying. I mean, from electric streetcars from Mars, right? But as doctors and doing limb salvage and reimplantation, we're really just kind of inching along as time goes. And so we got to improve it. And that's what we're going to talk about a little bit today. There's lots of these mangled extremity scoring systems for lower extremity. Talk about if they kind of correlate to the upper extremity a little bit. And you need a lot of tools for upper extremity limb salvage. Pulsizations, toes, and things of the sort, and flaps. And so we'll talk about this. So the outline, acute limb salvage, which really is replantation. The mangled extremity, which is kind of a subacute limb salvage. And then when we're in the chronic stage, what can we do? There's a little bit about replantation versus prosthetics, and it's obviously something that's constantly evolving. There's even transplants that many people are doing, and there's been multiple upper extremity transplants. And so which way is the best way to go? It's not totally clear. We'll talk a little bit about this Fuchan Wei paper a little bit later in the talk, but that just came out a couple months ago, and it's interesting for a lot of reasons. So I know you guys see a lot of mangled extremities. This is a patient who had a carjack fell on his hand. So when we're thinking about this and indications, contraindications for replantation, it's proximal. All 5 of his fingers are not vascularized. It's a crush injury, multi-level. There's some contraindications for reimplantation here, but because it's proximal, I think it's something well worth doing. We'll see how good of a job we can do. So everything's broken. Through the joint at the thumb and the small finger, and metacarpal fractures all the way across. So there's a lot of different structures we got to repair, preoperatively clean everything up. And then I think getting to the goal of having a good ultimate limb that works starts when you see them in the emergency room. It starts with patient counseling. You got to tell them the amount of recovery that goes into it, They're going to be in the hospital for a while. Mention the word leeches so you don't freak them out the 2 days. 2 days later, they won't remember it, but like at least they'll think like, oh, I heard that before. I think it's also valuable just to kind of mention prosthetics. You say we're going to try to. Most people who are coming into the emergency room, they want this thing replanted. All right, very few people are going to say take it off. I know it happens, especially people that are trying to get back to work, depending on the level of the injury. But most people come in, at least in my experience, want that finger back on. But you can discuss prosthetics at that time, just so they kind of hear it. It's in the back of their mind. Toe, it's also just like a total. Most people can't even comprehend the idea that you can put their toe in their finger. So I think it's useful to kind of start that conversation right at the beginning, just in case this doesn't work. There are options like prosthetics and toes that we can make fingers out of. I mean, I think the other thing when we talk about doing a good job with the amputation, and something that we've started to institute at our trauma center, is we take basically everything to the OR. Even if something is not replantable, even when we're talking about a digit amputation, the second year ENT resident who's like in the emergency room doing the revision amputation doesn't result in a good amputation. So we'll take things to the OR. It doesn't necessarily have to be that night. Do a really good revision amputation, make sure there's no dog ears and all these things on the end, so that when they do get to the point where they're putting a silicone or functional prosthetic on, it looks a little bit better, it fits a lot better, it makes the prosthetists and the OTs and everybody else's life a little bit easier. We won't talk a whole lot about the details of doing a replantation, but just some of the highlights. I think ultimately, when we think about replants, a lot of them don't do well, all right? You're doing, and I personally think, I mean, the core issue is that you're doing a tendon repair along with a lot of other repairs, and if you don't move that tendon repair early, it's not gonna do well, right? It's just, it's the basics. It's something we've known for 50 years. And so you gotta be able to move them early. That means getting good, stable fixation. IM nails, I think, have made my life a lot easier when it comes to this. You can put the pins in antegrade, retrograde, and you just put your screw over it. There's lots of different ones on the market. One thing I have changed about it, I will say, when it's like a true transverse fracture, like this is, I'll use compressive screws now to actually get good compression, because you see the gapping on this. I'll show you later. This one ended up being okay, but it's not ideal. 90-90 wiring is a great technique to work. It can be a little finicky at times, which is why I think the IM nails are great. Good, stable pinning also is helpful. You can move people with pins in. If you're gonna put pins in, you have to be confident enough that you can move their other joints even with those pins in. Even if they have a non-union, you can kind of deal with it later. But stiffness is just the bane of hand surgeons' existence, as we all know. And then for your neurovascular bundle repairs, your nerves or arteries, there can't be tension on it. If there's tension on it and you're worried about moving it, it's not gonna work. If you need a vein graft, need a nerve graft, you just gotta go ahead and do it to allow them to move them. And these patients, just like any tendon repair, they really should be moving 3 to 5 days after surgery, okay? And if your vascular repair is such that you're not confident in moving them at 3 to 5 days, then you're gonna, again, end up with a stiff finger, doesn't work, and the truth is the prosthetics are probably better than that version of limb salvage. Another thing, so when we're talking about, we'll shift gears a little bit just because of this patient, but when we're talking about a chronic limb salvage, I think just something to think about in the back of our mind. This is a patient who had a flexor tendon repair, okay, digital nerve repairs. Digital nerves, flexor tendon was repaired the first time, didn't really do a great job with rehab, ended up with a stiff finger, but also neuromas on both his digital nerves, incredibly painful. This whole story is not something we did, but then those nerves were cut out and reconstructed, totally appropriate thing to do for a neuroma. A year later, again had painful neuromas. So painful, wasn't moving his finger, and it was bothering him every day. Couldn't think about anything else, couldn't use the entire hand because of painful neuromas in his index finger. Then the next procedure he had was cutting of those digital nerves and burying them with TMR. So that finger is like now totally insensate, okay? still didn't work. So he still had pain. And so when we're thinking about this kind of patient, where you're in kind of a chronic limb salvage state, you start thinking maybe an amputated index finger is better than having this finger. And so it's a tough thing to think about. There's this great article for the residents when you get into hand surgery called Why I Hate the Index Finger, but you should all check it out. But so this patient didn't want that, even though we do bring it up. So we went and tried to reconstruct his digital nerves. One of the things that has helped a lot with replantations and any kind of nerve repair is this device called Nerve Tape. I'll show it to you here. It's faster than suturing nerves. When you're suturing the nerves on a replant, I'll try to show this video here. You're generally tired. You've done a long procedure. You've gotten the vessels up. The finger's bleeding and it's alive. And so, it says cannot play media. It's working earlier. But I'll just kind of talk through it. So, can you see my cursor there? Oh, here we go. Well, anyway, there's these little hooks. This is like a conduit, okay? It's an absorbable conduit. There's these little hooks on either side of the conduit. You can place the nerve into those hooks, and the hooks are very small that they only really penetrate the epineurium. Put the nerve on either side of it and just wrap it around. And so there's no suturing involved. You don't even need the microscope. It's very easy, it's very quick, and it helps quite a lot with the replants. It's a nice technique and something newer that we're starting to do. Post-op protocols for replantation, it's a tough thing. In general, we're just ignoring the extensor tendon. So we're really focused on the flexor tendon, getting that thing moving. You have to spend a lot of time with your hand therapist and the patient and get them moving. It hurts, everything like that, but when you're doing when you're just doing a flexor tendon repair, again, they have to move early. Now they have a lot of other stuff they went through. They have hardware in, so it's difficult, but they really got to work through it. If it dies, it dies. So if you're worried about your neurovascular repair, your artery, and you're worried that moving them is going to kill the finger, first of all, you have to think about how you're doing the repair, but at the same time, you just got to move it despite that, I think. And if the finger fails, it's still probably better than having a totally non-functional, insensate, stiff finger. And so we're pretty aggressive with our hand therapy now afterward, and we'll start it in the hospital. So, they have the replantation. 5 days later, OT sees them in the hospital, creates the thermoplastic splint, and starts them on a passive motion protocol. We don't do early active, for obvious reasons, but early passive motion protocols. The prosthetics are just too good now. And so having fingers that don't work so well is not good. So yeah, this is the same patient from earlier. We got 4 of his fingers to live, but not the most important one. And so you need a toolbox. So if you're gonna undertake limb salvage for the upper extremity and replantations, it's not just about doing a replantation, it's about doing all the next steps. Groin flaps or periumbilical perforator flap, either one's just fine. And then he's missing the thumb, so there's lots of different options we talked about, but a toe is a nice kind of traditional option. Separate all the structures and then repair it. It's a nice surgery. It works well. Has its own issues. So this is where he's at 10 months out. You can see, despite the gaps on those metacarpals, it does heal in with those IM nails, thankfully. And then 90/90 wiring for the thumb. When the fractures are through the joints on the replant, we'll primarily fuse them as well. Because it kind of makes the most sense to do. So this is where he's at 10 months after his injury. So like we said, undertaking replantation takes a long time to get them to where they can even use that hand. If they have, when we're talking about single digits or even transradials, if they're getting an amputation, maybe they're getting to their prosthetic and using that prosthetic earlier than that. So it's just something you kind of have to know. But at 10 months, he's able to move his fingers. He can grab a phone, he can use some tape. Depending on his job, he can get back to work. So that's where we're at. And I would argue for this, this is the limb worth salvaging. There are so this Fu-Chan Wei paper came out a couple months ago. He is probably one of the 2 most famous plastic surgeons in the world. He's in Taiwan. He does a lot of toe transfers. And they actually published this paper where they're talking about how toe transfers are outperforming replanted fingers, all right? And it's pretty impressive. I mean, they're very good at toes, so I don't know that everybody would be able to recreate this. And they're talking about toe transfers for fingers other than the thumb, too. So the small set of them was in the thumb, lots of them in the other fingers. But you can read this in two different ways. I think the way I read this is saying we need to get better replantation more than anything else, because it seems like a little odd that the toe would work better than the actual finger. We don't know, can prosthetics outperform toe transfer? Maybe not now, but eventually, I think it'll be at that point if we don't keep getting better at limb salvage and our toe transfers. There's also, this paper brings up like a paternalistic or patient-centered approach. So somebody comes into the ED and you think that patient's gonna do better with an amputation right there on the table, but the patient doesn't want it. Are you gonna say, we're not gonna replant this, or we're not gonna at least take it to the OR? And I think obviously every situation is a little bit different. Fujian Wei in Taiwan, they will toe transfer people that night, and I think doing that, trying to convince somebody to do that while they have their finger cut off in the middle of the night is not something that I would be able to convince anybody to do. So think about that. And again, large toolbox needed. Mangled extremity. So this is kind of in this subacute timeline. Sorry, I don't know why the slides kind of cut some of this stuff off, but this is a mangled extremity. So I think this is a lot of what you guys see. I know we're getting a talk about farming injuries a little bit later. But these are not necessarily non-perfused arms or extremities. These are ones that maybe have perfusion. There's quite an extreme injury to it. There's multiple things that are wrong. There's a bone, there's a nerve. There can be some vessel injury, and all these kind of soft tissue defects is generally a big part of this. And there are scores. This one's actually from our institution, NYU. But if you talk to the senior author on this, Dr. Thanek, people are not necessarily using these scores all the time. I think one of the issues with these scores is when we think traditionally about lower extremity salvage, we think about the tibial nerve. So if the tibial nerve is not working, then we used to say, okay, that lower extremity is not worth salvaging. Presumably, the nerves in the upper extremity are even more important, because they're so important for function as well as sensation. And that's not taken into account in some of these scoring systems, which, it doesn't jive with the way I think about it. So, I don't know that we can necessarily correlate it to the lower extremity in that way. The other thing I'll say about this is, like Dr. Ilon showed, some of these brachial plexus injuries where the patient, again, has a painful extremity, it's not working. They don't have sensation there as well. Like, that's a big problem. And even if those patients get brachial plexus reconstruction, they get gracilis flaps, all these things, if those things don't work, a lot more and more of those patients are opting for amputation because the prosthetics, especially with OI, can give them a decent output. So it's all kind of comes together a little bit. So this patient, a young lady who ATV rollover, had fixation, had a distal radius and ulnar shaft fracture, multiple CMC dislocations and fractures, had gotten repaired somewhere and then showed up to us a week after her surgery, large wound, dorsally, big problem. And so you're already kind of behind the 8 ball. And so this algorithm, I think, is kind of similar to the lower extremity in that you have a dirty wound, wound's got to get clean, okay? So the first step, most important step in any kind of limb salvage with a dirty wound like that, debriding it, getting to a clean wound. You also provisionally fixate your bone, so that's a lot of times an external fixator. If it's still dirty, you got to go back and debride it. And you want to limit the number of debridements you have to do. So this also, we have to think about like our basic principles of moving these patients early. And so the more you're kind of going back and debriding, you're just delaying their ultimate reconstruction, you're delaying their motion. And so you want to do as good of a debridement as possible, almost treat it like a cancer operation where you're getting rid of everything. And if you have to go back, you have to go back to make sure it's clean. We get solid soft tissue coverage, clearance of the infection, and then make sure you can put in your final fixation and repair all your structures. So this patient had external fixator, wound got clean. I used to lose a lot of these antibiotic beads, kind of gone away from it a little bit. I just don't know that they made a lot of difference. I think debridement's probably the most important thing at the end of the day, antibiotics, and having your provisional fixation to make everything nice and stable. Stable soft tissue coverage. This patient had We wanted to do an ALT, perforating anatomy was not so good, so she got a vastus, which is a muscle-only free flap. I mention it, just remember that, because then we'll talk about it a little bit later when we get to our end result. But it looks a little bulky now, right? But still has our external fixator on. She's got a big bone gap, okay? It's a little bit hard to see on these radiographs. Sorry, I'm a plastic surgeon. But reconstructed with a free fibula, end to side in the radial artery. This is another one of those times I'm thinking, so with the vastus hooked into her proximal ulnar artery, she's only got one artery going into the hand. So there's not a whole lot of arteries left. And so we think the fibula is the best thing for her, so we go end to side to try to preserve the blood flow to the rest of the hand. And then there's where she's at. This is 2 years post-operatively. And so you see how much that flap atrophied, okay? And so now trying to go back in there and do any kind of reconstruction of her tendons becomes kind of challenging. So it's one of the things I learned from this case. And so she ends up here. And these are not, you know, the reason I kind of show this, she is like she has very little motion of her fingers, okay? So she has an arm that she can feel, but it doesn't have great motion. She can certainly use it as a helper arm. Her elbow function is fine. But it's not ideal for a lot of reasons. And so anytime things you have to go back, or like you don't get it right the first time, your outcome is just a little bit worse. And now we start thinking, oh, is this limb worth salvaging or not? And I don't necessarily know the answer, but you know, it certainly is helpful for her in some ways. But it's hard to say that one day a prosthetic may not be better for her. So conclusions, just talking about all this, important to get it right the first time, motion early and often. You need lots of tools in the toolbox to repair bones, vessels, nerves, the tendons. If there's any kind of revisions, you gotta be able to handle that. I know we're talking a lot about non-unions later today, and secondary tendon procedures. You guys should recognize this thing on the top right. I mean, it's the AO basics, right? And we kind of get away from it when we think about these complex things like limb salvage and replants and stuff, but restoring anatomy as best you can, stable fixation, preserving blood flow, and moving patients early and often. It seems basic, but it's the way we can get better at limb salvage if we just adhere to those principles. And all the tools we use should hopefully help us adhere to those just AO basic principles. And the last case I'll show, just a similar way than Dr. Ilon finished his talk, is how amputation can be a form of limb salvage. And so this was a patient who had no less than 25 operations on her elbow, bad elbow trauma, lots of different attempts at reconstruction of ligaments, infections, had 3 different total elbow replacements. And so she's at this point where she's got a painful limb, she doesn't use it, she thinks about it all day, feeling is not great in it. And so she, 2 surgeries ago, is thinking about amputation already, maybe even more than that. And so when you think about that limb has already not been salvaged. You know, that limb is already not working. And so you can use amputation as limb salvage. And just like the starfish procedure that Dr. Ilon talked about, if you have muscles that work, you can preserve those, and those still will fire. And so because those muscles are firing, they can be used as signals for a prosthetic. And it's more intuitive that way, because they're just thinking about moving those muscles. So they think, oh, I want to bend my fingers, their flexor tendons will fire. Those flexor tendons are preserved, and they're firing off in the elbow. And so the prosthetics can sense when the patient wants to move their fingers and then react to that. So there's no learning involved. And it's a nice technique. I don't know if these videos are going to work either. Yeah. But that's it. Thank you very much.
That was great. I appreciate that. We definitely have some time for questions. I think in a similar vein with discussions with trainees, and this is something I know Joel has talked about a lot. When we say, with residents and evaluating these patients first in the ER, it's oftentimes the first person discussing or managing these issues with the patient really sets the course for for the rest of their care, the rest of their treatment. You alluded to this a little bit in your talk, but I'd be curious to hear some of your discussions with the residents in terms of managing those conversations early on, whether that's a individual digit where you're considering a replant, mangled extremity. I think a lot of times that's a challenging conversation for us, and then especially for residents, fellows dealing with that in the middle of the night. It'd be interesting to hear some of your thoughts on that.
Yeah, I think it's really challenging. You have to think about it from the patient's perspective. They are in the most stressful time in their whole life, probably, is when they're sitting in front of you right now. I mean, they're missing a finger, they're missing a hand. And I will also say, whether they're missing even if people are missing half their finger at the zone 2, to them, it is a huge deal, okay? To you, you may think it's not that big a deal, it's not their whole hand, it's not their whole arm. For them, it is a huge deal. And so you really have to remember that and try to think of the mental state that they're in that moment. And so being patient, I think, is very important, and being realistic. Most of them, again, are coming in thinking you're going to put this back on, the finger's going to work perfect. It shouldn't be that hard. It's a really small area. And so you got to downplay that immediately and tell them there's a good chance it's going to work. The vessels are really small. The nerves are really small. We're not great at repairing nerves, quite frankly. I mean, we can put them together. The nerves are going to take a long time to get better. The recovery is going to be long, and just mention every part of it. And it takes a long time. And sometimes the residents are also stressed out because they have this pressure from everyone to get into the OR as fast as possible, right? And so if you have a team where one person's getting the OR ready, the other person's talking to the patient, I think things kind of work a little bit better. I think that's it. Take time and go through as much of it as you possibly can. They made it even lower.
This actually follows right in that same vein, that's fantastic talk. And again, that's something that's outside the realm of what we do on a daily basis. So it's so important for everybody to hear that. Can you talk a little bit about the resources that are necessary to run a replantation center, which we are not, and what goes into that, from a logistics standpoint, how many times you're on call, how many replants you do, and who's available to help you. I think that's also a discussion we don't really have.
Yeah, it takes a lot. I mean, it takes a village. It takes everything from the top to the bottom. I mean, the surgeons, the nurses, the residents, everyone has to be on board. But having nurses on the floor that can manage it, if you're a place that does a lot of free flaps, it will help. But them being trained to put on the leeches is a whole thing. I mean, I've done replants at a lot of small hospitals too in Long Island before I was at NYU, but there's just different levels of comfort with all that stuff. Intensive nurse monitoring afterward, so like an ICU kind of situation, absolutely necessary. In the operating room, you need to have the microscope, you have to be able to get into the OR 24/7. And if you're gonna have a replant center, you need surgeons on call 24/7 who are capable of doing replantation. So you don't want somebody and the other part of that is when other emergency rooms are accepting these patients, they're also stressed out. So it's also something to think about when we answer the phone and we do transfer centers. I don't know if your residents do that or staff does that, but.
No, we're the one calling you.
But I guess we understand that you guys are in a stressful situation too. And so you're trying to offload that patient. And so the first thing we'll tell them to say is, we'll take the patient and then ask for the story. Because if you go the other way around, then sometimes the other person on the phone, I'm sure you guys are very good, but sometimes it's an emergency doc, and they are just saying whatever they can to get you to take the patient, all right? But if you just tell them, hey, we'll take it, I just want to know the story to help myself get set up, I think that helps quite a lot. There's a paper from this guy named Kevin Chung from Michigan looking at replant centers and how many replants you can do in a year to increase your odds of success. And it's actually only 3. I would have thought it would be more. But I think there's just a lot of places that are not well set up for it and maybe do 1 or 2 a year. But if you're at a place where you're getting at least 3 a year, actually your success rates can be fairly decent. And I'm talking like 70%. That's, replants die all the time for no reason. So it's challenging. It's a challenging thing. As far as how often we're on call, it's always in flux. People come and go all the time. But I think right now I take 7 days a month in Brooklyn, which is not a replant center, but we do probably 4 or 5 replants a year there. And then at Bellevue, which is our big trauma center, it's much less. I think it's like 1 in 8 right now because we have so many people. And then at Bellevue, it's more like 2 a month or so as far as replants go. So our fellows get very good, and the residents very good at it too. We also have a lot more help from our trainees at Bellevue than we do on the Brooklyn side. It's just 2 kind of different models. But hopefully that answers some of that. Yeah.
Hi, Dr. Agrawal. Thank you so much for this lecture. As someone who's interested in upper extremity hand, it was very interesting for me. My question for you is, as a resident early on in their education career, what exposures, technical skills, and resources that do you think us as residents can gain access to that might help us decide on whether we want replant as part of our practice?
Yeah, it's a good question. If you're a plastic surgeon, you should take AO Basics and AO Advanced courses. If you're an orthopedic surgeon, you should take, taking a micro course I think is very helpful. There's lots of good ones around the country. The one in our city is Columbia that the ortho hand fellows go to. I think those are very valuable. I think just getting any experience whatsoever, things do translate. I mean, we're surgeons. One of the things that's appealing about plastic surgery and orthopedic surgery, I think, is that we operate all over the body. And so you're really learning techniques, okay? And those techniques apply to different areas. And so, believe it or not, doing spine cases where you're using the microscope, some of those techniques will translate to using the microscope. Doing any kind of peripheral nerve repair, I know you guys do a lot of nerve repairs. I mean, those skills absolutely translate. It's different when you're doing a vessel, but if I'm being honest, I mean, doing a good nerve repair where you're just trying to grab epineurium with the suture is probably harder than doing a vessel repair. The vessel repair, just the difference is the nerve doesn't go down in the middle of the night, you know, so it's less stressful. But actually the technique of doing it is harder. I mean, your margin between the epineurium and the fascicle is like nothing, right? But on a vessel, you got the width of the vessel, which can be, you know, a millimeter. Sorry, not a millimeter, but it can be a little bit bigger. So getting involved in any of those cases, doing a micro course, I think is helpful. Going to, if you're thinking about doing hand fellowships, and I think Dr. Allen, he's very involved with the ortho hand fellows, but going to a fellowship that complements your training is extremely helpful. So if you feel very comfortable with all the bony stuff, maybe doing somewhere that has a little more of a kind of general fellowship, I think is extremely helpful. And that's how you become a complete hand surgeon, is having both sides of it.
I would just add to that, early in your training, I'm going to put a plug in for the ASSH has something called Hand E, which if you know about it, it's like an app. Kids love apps. But there's microsurgical curricula with videos. You know, don't worry, you don't have to read anything. They have a whole course, and it's super easy, and that has made a big difference in our residents. Just being exposed to microsurgery, the techniques, how you take care of the patients before and after surgery, they can really allow you to hit the ground running when you actually start doing these cases. So take a look.
Great. Thanks.
All right, we are going to take a 10-minute break, so we'll plan to meet back here at 9:35, and then we have some shorter talks as we work towards the conclusion of our session. Thank you. All right. In the interest of staying on time, we're going to go through our series of shorter 15-minute talks. We have a section for questions at the end. So if you have questions, write them down or take notes. And when we do our panel and Q&A, we'll have time for questions from everybody. So our next speaker is Dr. Ken Corey. He's an orthopedic traumatologist at Geisinger in the Northeast. He's also the residency director for our orthopedic residency in the Northeast, and he is going to be talking about managing bone loss and non-union in the humerus. So, thank you.
All right, thank you all. Let everybody start to settle in, but just like to say thank you for everybody that set this day up and creating a great experience yearly for our residents of all the programs. So really appreciate that. We're talking about non-union of the humorous. I have no disclosures. Objectives, so we'll go through the different locations of humoral non-union with special attention turned towards the diaphyseal non-union because that's sort of I think the crux of where we have decisions that are more challenging. We'll talk about causes, types, treatment options, and the challenges of those treatment options. And then we'll touch on segmental bone loss and some options for that. And then if time allows, we'll talk about a representative case. So again, distinct sections of the humerus to consider, each with their own challenges and options. Proximally, it has a unique option, especially we're talking sort of proximal metaphyseal and then proximal to that, of having the option of resecting the non-union and then replacing it with either reverse total shoulder or hemiarthroplasty, depending on the patient's age. And so it does give us a unique option to that anatomy. Otherwise, RAF and bone graft is going to be similar to our diaphyseal sort of conversations. So again, reverse non-union, we can essentially amputate the non-union out of the body and replace it with internal prosthesis, depending on the patient's age. Reverse is appropriate versus hemiarthroplasty, and depending on the amount of bone loss, proximally you can talk about sort of an endoprosthesis with either a reverse or hemiarthroplasty being part of that. Distal, similar. Arthroplasty is an option, less so. But again, in certain patient populations, that can be an option to essentially resect the non-union and then replace it with total elbow or hemiarthroplasty elbow. And again, RAF or bone graft is still a viable option, but it's going to be similar to the rest of the discussion about the diaphyseal injuries. So again, low demand patients, we can resect the non-union and do a total elbow to alleviate concerns of the bone not healing, so long as they fit the requirements of people who have, the limitations that come with the total elbow. And so the metadiaphyseal to metadiaphyseal, much more common. Still not the most common post-surgery. It's about a 2 to 10% risk of a non-union. I think the thing we see more commonly are things that are treated non-operatively initially and maybe not even given the chance to go on to non-union, but show signs of not healing, and so then we act on that. Various causes and then the treatment options we'll discuss. So fracture pattern plays a role. So proximal third, metadiaphyseal, and then those that have oblique or spiral patterns are more common to go on to non-union. And then patient factors, right? So obesity, smoking, metabolic abnormalities, and advanced age are all predictors of people who might go on to a non-union. And a lot of people can be treated in Sarmiento as pictured there from the original paper, but not everybody is young and healthy and has the muscle tone demonstrated in the initial article from 50 years ago. So we are seeing more of these people that are obese, smokers, diabetics, people that don't heal their bone as easily. Other causes, infection, bone loss, soft tissue damage, insufficient fixation, right? And so these are all reasons that the bone may not go on to heal. And then as far as the types, just as any other bone, hypertrophic versus atrophic. Hypertrophic being a bone that has the biology to heal, but not the structural stability to heal. Right? So we'll see it a lot in non-operatively treated humerus bones that could heal biologically, but don't have the structural support to heal. And so by stabilizing them, we give them the support and they can go on to heal. Or the implant that was chosen is just not adequate, for healing. And so therefore, in those cases, we need to improve stability, whether it's just initiating surgery in the first place or revising something that's more stable. Atrophic, it's insufficient biology to heal, right? So it's been stabilized, but we're just not seeing any healing happening at the fracture site. And so it's a sign that the biology is inadequate. And so then we need an intervention to improve both the biology and the stability. And so that is, typically compression plating with bone grafting, right? So we need both of those things to occur. And we'll get into it in a little bit, but simply bone grafting it alone, like say you thought that this fixation was adequate enough and you just wanted to bone graft it, that is a precursor to it failing, the non-union repair surgery. So you have to add new hardware and you have to rule out infection as part of the treatment for this as well. So segmental bone loss, right? So these are the challenging ones. It's fairly straightforward to go from a bone that has a hypertrophic non-union, you plate it, and it goes on to heal. Or maybe you just need some bone graft and compression plating. But what do you do when you have this, sort of large segment of bone that's missing? You can't just simply put a plate on this or put a nail in and expect that to work. So some different options, but typically they involve some bone grafting, and for segments like this, you really need some microvascular help. Not a lot in the literature on this. There's some case series and some case reports, but these are some examples of people using sort of a mescalet type technique, which is bone grafting, creating an induced membrane, and then antibiotic spacer, creating an induced membrane, and then coming back and bone grafting. So when I say it's mescalet-like, because they add an extra step in here, and then we'll go to the next slide where they added an even additional step. But you see antibiotic spacer for the large segmental defect, and then in the middle picture, they've come back and they've actually used a fibular allograft supported by autograft from the iliac crest, and then plated it. And then you see that this has gone on to heal with that fibular strut allograft. There's also examples in the literature of people doing something similar with fibular autograft, but not vascularized. And then on the left-hand side of the screen, this is a case series where they had large segmental infected non-unions, resected the bone, antibiotic spacer with an X-fix temporarily, IV antibiotics, came back and did a vascularized fibula with some augment of iliac crest as well to get those to heal with a plate and screw construct. And then on the right side of the screen, similar idea, right? So you can do thin wire frame for this as well with a fibular strut to help support the healing process as well. And then not pictured, but other options, if you're in the distal third, you could do a pedicularized radial flap with a radial artery that can be brought up to the humerus. So you have to have enough, you have to be close enough to the forearm that you can reach. And these situations where you're doing these large fibular constructs are usually for 6 centimeters plus defect, and the more proximal ones, whereas the more distal ones and smaller defects, you may be able to use the pedicularized radius, or you could even just shorten. So you can shorten the humerus up to 3 centimeters, maybe 4 centimeters, and still have pretty good function. So those are sort of the options for these large segmental defects. Again, autograft, vascularized autograft, allograft, pedicularized autograft, thin wire frame, and some transport techniques can also be utilized. So the challenges are that if you're trying to revise something that's already been fixed, there's actually a 20% risk of recalcitrant non-union. And that's compared to 3% if you're taking a bone that was treated non-operatively and trying to stabilize it. So definitely a higher risk. And so you have to be aware of that. You have to let the patients know that there's just this risk of it not working, right? So 79% success rate is not usually what we're looking for, right? In our typical orthopedic surgery, we usually have a much higher success rate than that. So you just have to be aware that they've had prior surgery, scar tissue, damage to the bone from trauma, from prior surgery. They're going to have a harder time healing the second time. And then actually each time you go in, they have a harder time healing, right? So the risk of persistent non-union increases to 33% if you keep trying to heal this. And that's where really calling your microvascular colleagues to do something with better biology is really going to be the answer once you've had a recurrent problem. The biggest thing is also ensuring that you've ruled out infection, right? So infection will be a cause of persistent failure. And then, as I mentioned before, if you don't revise the fixation, it's also going to fail. So I think we have time just to go through a quick case, 45-year-old female, pedestrian struck with a polytrauma. She also has a history of a right below knee amputation, so she uses her arms to sort of help get herself around as well, and she's a diabetic. So pretty straightforward fracture. She was offered fixation, and the index procedure, you could make some critiques of this certainly, as far as implants, maybe the reduction is not perfect. But I think most of us have seen these things go on to heal pretty reliably, but sometimes they don't. And so she was diagnosed with a vitamin D deficiency, and despite correcting that, it progressed on to a non-union with failure of the implants and what looks like a hypertrophic non-union. All right, so persistent pain, implant failing, 10 months out from the index procedure. So she went on to have a revision, bone grafting, compression. Graft was taken from the proximal tibia and did reasonably well for a while, but still at 11 months, we're still seeing persistent non-union and still having pain. And so the decision was made to go back again, this time with even more fixation and bone grafting from the iliac crest. And at 6 weeks, looks like it's progressing better than any of the prior surgeries and healing. So, again, the main points are humerus non-unions are not that common, but when they do occur in the setting of surgery, we need to make sure there's no infection, we need to revise the fixation, and we need to add some biologic help. In recalcitrant non-unions, we need to consider vascularized bone grafts, whether that's a free fibula or pedicularized radius. And the special techniques are needed for those larger segments as well. And I guess, again, the big thing is to talk about with the patients is that just because we're doing a surgery and changing the techniques, there's still a fairly high risk of failure. And so we have to be aware of that. Thank you.
All right, I'm up next. I'm going to be talking about bone loss in the forearm, strategies for success. I'm going to take, I think, a lot of the principles that you heard Ken talk about and kind of put that in the context of some cases here. These are my disclosures. So when we talk about managing bone loss and non-union in the forearm, or non-unions with bone loss, I think we have a few options. So acute shortening. You often will read in textbooks that you can shorten the upper extremity up to 4 centimeters with minimal consequence. I don't know how well studied that is, but it is certainly an option, particularly if we're talking about small amounts of shortening and you just want to get end-to-end bone contact. We have non-vascularized autograft structural options, crests and other places, and we will typically talk about using a structural graft, non-vascularized, for defects that are less than 4 centimeters. And again, I think that's a pretty reasonable guidance for some of these. Induced membrane or Masquelet technique, there's some different variations of this. I like to think about this as sort of optimizing your biology prior to proceeding with the second stage in grafting. And then certainly we have the big guns, vascularized free fibula is certainly an option, especially in persistent non-union with massive amounts of diaphyseal bone loss, even double barrel, free fib. Then we have the salvage options. My apologies if any of my colleagues are big ring fixator advocates, but people have very passionate opinions, I think, in both directions regarding the ring. Then we also have the one bone forearm, which is certainly an option in some of these mangled limb cases where you're just trying to get a stable platform for a functional reconstruction down the line. And the problem here is that that's only the bone, right? There is so much else that's often going on with these cases, as I think Nikhil and Omri have kind of alluded to. And when you start to think about where you're trying to get, it can start to make your make your head spin a little bit. And so, I think this has been covered, and I try to have a general approach to these cases with bone loss, mangled upper extremity. I think the first one is a team approach. We are very fortunate to work in an environment where collaboration is very easy. I have done collaborative cases with multiple people sitting in this room, and I think these are the times to really engage your partners. I learn a lot every time I operate with one of my partners, and I think these are the opportunities to really do that. I like to think of structure and then function. And so, you see a mangled extremity in the emergency department, and you're trying to think about what the end result can be. And I think you have to remember to get osseous union and soft tissue coverage before we start talking about what we can do in the reconstruction. You have to keep those reconstructive options in mind for down the line as you're trying to get osseous union. But we really want to make sure we can get the bones to heal and we can get a soft tissue envelope that's going to set us up for success down the line. And then having a clear goal for each procedure. It's not the we don't have time, we'll just list this for a washout and do it. I mean, you should go to the operating room with a very clear intention and purpose and how that's going to impact your next steps. And so there's a lot here, but I try to keep these 3 things in mind as we work through this. I thought this was a fascinating portion of the discussion that I think Nikhil got into a little bit about, a paternalistic and a patient-centered approach. And these are extremely challenging injuries to manage. And as you go through 5 years of a residency and then subspecialty fellowship training, these are cases that we're texting our friends hey, what do you think about this? And so shared decision-making is key, and I think that's a very difficult balance of how do you take your knowledge and expertise, explain that to a patient in maybe a 15-minute window, and then expect them to make a decision based on that. I think it's really hard, and I love the pilot analogy, right? You can choose to get on a plane, and there's a number of different destinations that you might, want to go to. But at the end of the day, you're not going to tell passengers aren't really going to tell the pilot how to get you there. We know where we want to go, and in some levels, you have to rely on the expertise and training that you've acquired to get them where. There's going to be turbulence, there's going to be connections, there's going to be weather delays. All kinds of things. But I think it's important to be the pilot and really define the course, right? And being able to get a patient to understand, here's the options, here's the destinations we can go to, and then it's on you to craft the course. And I think that's something that comes with, with time and experience. But these are conversations that you have to have at the time of injury, time of presentation, to be able to do that. So I think there's a lot of airline analogies with, with orthopedics and healthcare systems. And I think this is pretty applicable. So here's a case. This is one of the first cases I did in practice. And, with most great stories begin, from the outside hospital. And this was a young 26-year-old MVC fleeing fleeing the police and had a real complex series of upper extremity injuries. Prior to presentation, had an RF of his scaphoid, X-fix of distal radius with a cement spacer in the metaphysis for some substantial bone loss after the debridement. He had an ORF of a distal humerus fracture as well as fixation of both proximal and distal ulna fractures. And so the first time I met this patient was with, these films. And I think in this case, you have substantial bone loss in the metadiaphyseal region of the distal radius, and they've kind of already set you up for an option. They have a cement spacer. We have bone loss. We have the distal ulna. They've been provisionally stabilized. And so for me, this seemed like an easier decision to move ahead with the second stage of a masculae. And in this case, it was a smaller defect, around 4 centimeters. And I did the modifications that Ken alluded to, where I took structural iliac crest graft in addition to corticocancellous graft and used that to get a little bit more early stability and a little bit more bone inside that induced membrane. And again, the idea there is that's creating an optimal biologic environment for healing. So you can certainly add structural graft in addition to the initial description where you're adding cancellous graft. And at the same time, we fixed the ulna, and here he is a year later, had gone on to union both his radius and ulna. And I think you can be critical of the distal radius reduction, but at the end of the day, he has intact healed diaphyses, and this is somebody that's set up to get some good hand and limb function despite a pretty serious initial injury. I think this case takes us through a little bit more of a winding road. This was in June of 22. As a 40-year-old male, was in an ATV rollover. These were his initial clinical images in the emergency department, and a substantial mangled wound to his forearm, bone loss, highly comminuted diaphyseal fractures, instability at the elbow, which is a favorite topic of mine. There's a lot going on, difficult management early on. And so, you look at this and it's, the class of how to eat a whale, it's like one bite at a time. This is not somebody that you're going to fix in one surgery. And these were multiple cases from multiple of my partners, sometimes together, sometimes separately, multidisciplinary care. And so I try to organize, my thoughts by region or area. So what problems do we have? What are we dealing with? We have radius with substantial bone loss. We have an ulnar fracture. We have radiocapitellar dislocation, probably an IOM injury. He's missing all kinds of skin dorsally. He has no wrist or finger extensors. He has no EPL. And on top of that, he has a complete radial nerve palsy high and a high median nerve palsy. His ulnar nerve is intact. He's got a sensate and perfused hand and really prefers options that are going to let him keep his arm. And so I try to keep this list in mind, say we're not going to address this all in one surgery, but we have to think about all of these components as we start to plan some initial operations. And so I think the first thing here is get it clean. So some provisional fixation for the ulna and a really aggressive debridement and irrigation. And I think when we talk about every procedure should have a goal, the goal in this first thing is get it clean and get it covered as soon as we can. That's going to set you up, I think, there. So we go from those horrible-looking clinical images in the emergency department to, after a second debridement, he has a pretty clean wound with a spacer and ready to start thinking about soft tissue coverage. Again, we went back 2 days after injury and 2 days after his initial debridement for an additional debridement. Our plastic surgery colleagues were involved from the start. He had an ALT free flap, and at the time, that'll look somewhat familiar, but had his radius fixed, again with a cement spacer in that distal diaphysis. This is where I started to get involved, and I'm starting to check through the problem lists of what we have. And the first thing that I'm looking at for this, now that it's clean and covered, is he has bone loss in the radius. And so very similar, induced membrane technique with iliac crest autograft. He already had a cement spacer there. And so I felt like in this case, while we have a variety of those options we talked about in the beginning, this is what he was set up for. So, again, as we talk about turbulence, encountering bumps in the road, he had a non-union of his ulna. And still with a persistent radiocapitellar dislocation. So, we're 4 months after injury, and I'm going back to the list. His radius is healed, his ulna is not healed. He still has radiocapitellar dislocation, which makes me sad. We've solved our skin problem, but if we look at now our tendon and nerve, fortunately for him, his high median nerve injury was recovering. So now we have a good ulnar nerve and an improving median nerve. But this is a difficult situation with no radial nerve function. And even if he did, the wrist extensors, finger extensors, and EPL are gone. So that really limits when we talk about options like nerve transfer or even tendon transfer in some of these cases where we don't really have a lot of great donor and recipients. So we're now at 5 months, and as I'm going through this of trying to prioritize goals for the next surgery, we need to revise his ulna. We need to do something where, once we can get the ulna to heal, we can now start thinking about function and the joint. So again, in a staged manner, we revise his ulna. Because of the tendon and nerve loss, I felt that a wrist fusion was going to give him the best opportunity to optimize some of his hand function, since he did have a good median ulnar nerve and had good finger flexion. We did do some tendon transfers after that. We used the FCR down to his EDC and used his palmaris to try to get him back some thumb extension. I think a big component of this that we don't always talk about is trying to maintain passive motion during this time. So he had developed a stiff elbow. Fortunately, he had a stable on a humeral joint, and we were able to do some things to optimize his elbow function as well. So as we fast forward to 2.5 years, his radius and ulna had healed. He had a stable on a humeral joint and on his way to a functional recovery. And I'll put this plug in because I think Omri did an excellent job of covering this, is that really high rates of depression and PTSD. I think early referrals to mental health services are critical. It's like we're talking about reconstructing their limb as their lives can be falling apart in front of us. I mean, the marital issues, occupational issues, all of these stressors that don't get addressed in a 15-minute visit with us are critical. And I truly believe one of the most important things that we can do for these patients is to get them referred. Patient was perfectly fine with me including him in this video for presentation.
Bend,
But this is
straighten.
a functional result a year after that.
Good. Now
So
elbows in
now
close.
like 2.5
Palm
years.
up,
So
down.
Not perfect.
Up, down.
By any means, but I think achieved a lot of
Good. Bring your elbow in like
goals.
this.
Very realistic about what he
And do palm up, down.
what he wanted to do. I think
Good. Now
a huge
fist
advantage,
open, close.
of living in central Pennsylvania, which I don't think Omri and Nikhil are getting many squallets, but this is a squirrel wallet that the patient had made for us at the conclusion here. The googly eyes kind of freaked me out in a little bit, but this is one of. This might be the best patient gift I've ever gotten. So you too can end up with a squallet. And that's it. Thank you. All right, so for our next speaker, I'd like to introduce Chip Levitt. He's a plastic hand surgeon on Geisinger Northeast, part of our residency program, and he is going to talk about soft tissue coverage options in the mangled upper extremity.
Trying not to screw this up. All right. Thank you, everyone, for the opportunity to talk about some more of the soft tissue side of things. I think Dr. Agarwal's talk was a good segue into a lot of this stuff. I have no conflicts of interest yet, hopefully. So starting off with goals of reconstruction, especially with the soft tissue side, it's more than just sort of filling a hole, so to speak. There's a few main goals that we want to consider when doing soft tissue reconstruction in the upper extremity. I would say the first thing is making sure you're able to salvage the limb, and so that involves making sure that the wound and the defect are able to heal. If necessary, you also want to reconstruct any composite defects that may be in place within the hand or forearm or higher up in the upper extremity. And then lastly, it's one thing to sort of save the hand or upper arm, but you also need to make sure that it's functional. And I think a few folks have already talked about that to a certain extent. But what does that mean? That means motion and protective sensation, especially in the hand. So the initial assessment when you're presented with these cases, I think the first, question, I don't know, it depends on whether or not you're seeing them in the emergency department or as a consult as like the plastic surgeon being consulted to see an orthopedic patient. But making sure that there's been an adequate debridement is crucial because any reconstruction you do, if there's still non-viable tissue, is going to fail. And whenever you're talking about doing autologous tissue transfers, failure means that you've created a new wound and a new problem in addition to the other one that you were first there to address. Next questions you want to ask are what is missing, but also what is still there. Is it a skin-only defect? Is tendon involved? Is nerve involved? Is the limb perfused? And how wide is the zone of injury? Because that'll dictate what kind of reconstructive options you have further down the line. And then, as Dr. Grandizio talked about, there are functional concerns as well. Is the fracture stabilized? Because if you don't have that bony framework in place, again, your soft tissue will also fail, and you'll be going back a lot more times for even the bony stabilization first, which can compromise the soft tissue stuff. So it all goes hand in hand. And then you also want to, be considerate of, are there exposed nerves, arteries, and tendons, because they do not do as well with some of the traditional wound care methods. And so that also involves a close collaboration between, if it's a separate team doing the reconstruction as opposed to some of the fixation. Sometimes as a hand surgeon, you're doing both. So in those cases, it's good to have a teammate in the same field as you as well. I'm not sure, given the audience is mostly orthopedics, how familiar you are with the reconstructive ladder concept. But basically, it's a framework for considering the complexity of the reconstructive options you have for a given defect. So on the lower rungs, you have the simpler things like letting the wound heal by secondary intention. Further up, you have skin grafting, and then higher up is things like free flaps and local regional flaps. One of my mentors in residency used to joke that as we were doing more and more free flaps, jumping to free flaps for things, he called it the reconstructive rocket. But the reason it's happening is because sometimes the more complex solution is actually the way to get to a functional recovery faster. Now, there are caveats to that because it takes a village, as we've already talked about, for free flaps. So it's not always an option, and sometimes things like negative pressure wound therapy, dermal substitutes really help. Doing simpler things can really augment the recovery and get patients functional a little bit sooner depending on the defect. So with that in mind, I think the first thing is you don't want to forget the simple things. You wouldn't necessarily allow a mangled extremity to heal in by secondary intention, but usually they have more than one injury at some of these sites. So for example, if you have a big forearm wound that you're mainly focused on, well, if their fingers also have wounds and you don't address those, the whole point of your reconstruction is going to kind of be sabotaged. So Vaseline and Coban are really a powerful adjunct. You can see here someone even with denuded bone can actually granulate in with enough time and patience and keeping the wound clean. But the key is to keep those wounds moist, and that can help address multiple sites of injury because you don't want to be doing free flaps to every finger. The other thing is, and I think Dr. Grandizio talked about it, you need to keep the joint supple during this time because oftentimes these patients need multiple debridements, and there's also a period of recovery where you need to protect whatever bony stabilization you're doing, but you also need to take care of the wounds. And so removable thermoplastic splints made by inpatient therapists is really crucial in allowing that to happen because, again, if you let them get stiff, then any transfers you do, any nerve transfers, tendon transfers, all that stuff is pretty much going to fail. Another adjunct I mentioned before are dermal substitutes. So these are artificial matrices that allow ingrowth of skin cells. The beauty of them is you don't have a donor defect. They've really come a long way with the advent of negative pressure wound therapy as well in terms of optimizing some of what you can get away with. They're usually more for skin-only defects, but that's not always the case. Anecdotally, some products are better at providing a gliding surface for tendons, which is really important in the upper extremity. And my personal preference is for the less biologic, the better. So the more artificial, there's one that's a polyurethane matrix that anecdotally some of my mentors have had a lot of success with because it allows, again, early active range of motion, and it's so artificial the bacteria can't even really feed off of it. It's not an ideal situation, but in patients, not everyone can get a free flap, and not everyone wants an amputation, as we've seen before. And you can see here in a patient with missed compartment syndrome, where you have nerves and arteries are the only thing left in the volar forearm, and basically a non-functional limb. In a patient who refused amputation, polyurethane dermal matrix actually healed in, and eventually the patient was managed with skin grafting alone. Moving on to kind of the more complex reconstructions. So there are three general types of flaps. Local wound flaps. Local flaps are primarily involving the skin adjacent to a wound to cover it. And then regional flaps, which you're probably a little bit more familiar with, they generally involve dissecting out a vascular pedicle so you can move them out further without having to cut into the vessels and then having to do a microvascular anastomosis. The one you're probably most familiar with is a gastroc flap for knee coverage. That's sort of halfway in between a local and a regional flap. But again, you don't have to do microsurgery for that one. When it does come to flap surgery, there's definitely a lot more logistics involved. So things you have to think about, some of it we've covered already, is where's the defect, but also what recipient vessels do you have access to if you're thinking I might need to do a free flap. Will my flap reach as far as I need it to if I'm using a pedicled flap? Are my vessels long enough for a free flap to reach where they need to? If not, do I need to be doing a vein graft? A lot of times you need to do a nerve graft for segmental defects. What is the type of tissue that you need to address? So we try and replace like with like as much as possible, not always the case. But is it bone, muscle, tendon, nerve, or is it mostly a soft tissue, skin, adipose tissue to cover exposed tendons? And then when you're doing the surgery, how do you go about doing these longer surgeries efficiently? Do you have a two-team approach? So is one team harvesting the flap while the other one is preparing the recipient site? Do you have to move the patient in the like during the case halfway through once you've taken your flap to then put it back to then inset it? Because obviously that'll take away a lot of time, and then you also have a free flap that's sitting out non-perfused for a lot longer, which increases the risk of it going down afterwards. Also, we've touched about this as well. The resources needed to manage these patients afterwards in terms of free flap monitoring is pretty substantial. The usual protocol for any free flap is Q1 hour flap checks. Sometimes it's with the residents. The more you do and the more it's established, it's usually done by nursing, even within the first couple of hours after surgery. And so that can really expand the amount of manpower you have helping to manage these complex patients. In terms of timing and what type of flap you're using, thankfully with negative pressure wound therapy, they've done studies that show that overall the outcome doesn't really change, no matter how, depending on how, you don't have to do it immediately in the middle of the night. As Dr. Agarwal mentioned, it is better to do them sooner rather than later, but that's partly because a lot of these studies don't take into account stiffness as a bad outcome. It's more looking at flap failure and return to OR, which is sort of a different thing. The caveat to all this, though, is earlier reconstruction leads to decreased length of stay, which is better for everyone. But you also want to make sure with these complex surgeries that you have the team that's used to doing this available so that you're not doing free flaps in the middle of the night. In terms of what type of flap you would use, fasciocutaneous and muscle flaps are sort of the two main types of flap, generally the free flaps. And historically in the lower extremity, I think it was called the Godina protocol, it was viewed that muscle flaps were better. That's subsequently been debunked, and actually there are advantages to either, which you can use to tailor to your specific needs. So I won't go into all of them, but there are a few workhorse flaps that I think even as orthopedic surgeons, if you're not the ones doing them, it's helpful to be aware of them so that, again, when you're collaborating as a team, you kind of know what to expect and how to more efficiently plan to optimize the patient's outcome. So first of all, regional flaps, these are a little bit simpler. You don't need to do any microsurgery for them. The reverse radial forearm is going to be far and away the most common one in the upper extremity. It's thin, it's pliable, it creates an excellent gliding surface for tendons underneath them, so it's used often in the back of the hand. It doesn't, as I said before, it doesn't require vascular anastomosis. The biggest problem with it is in a mangled extremity, it is much more likely to be in the zone of injury. And if you take a skin and fascia flap with it, you have to do a skin graft. There are iterations of this where if you take a fascia-only flap, you can have a pretty negligible donor defect, which I'll show you an example of. This is one from fellowship. It was a patient who took an AK-47 round to his forearm. You can see there's bony and soft tissue defects. We temporarily stabilized him with a dorsal spanning plate, but he still has exposed tendons and an open wound with tenuous soft tissue coverage over the hardware. So we elevated a fascia-only reverse radial forearm flap, and you can see it's thin, it's pliable, it conforms to the defect quite nicely, and all he's left with in terms of a donor defect is that long single incision instead of a whole rectangle of skin graft. As those flaps, the edema resolves, you can see the contour can be pretty remarkable. With mangled extremities, your regional flap options may not be large enough, they may lack the necessary tissue for the defect, or they may be involved in the zone of injury, so that's when free flaps really come into play. I think I mentioned before, the two main flavors are muscle flaps and fasciocutaneous flaps, which again, there are variations on those themes, but just thinking big picture. So the workhorse flap for free muscle flaps is going to be your latissimus dorsi. There are others, Dr. Agarwal mentioned vastus, but that's definitely less common than the latissimus. The nice thing is about that flap is it's gigantic if you need it to be, and muscle flaps really conform well to the irregular surfaces. They're great for filling in dead space because if you have dead space, again, things aren't going to heal. You end up with infections underneath there, and you have weird contour irregularities. The problems with them, though, are they do stick to things. Tendon gliding is a concern post-operatively, so people get stiff quickly, so that's not an ideal situation. Theoretically, if you're doing a masculé technique, it may be harder to elevate them, although there are papers saying that the outcomes are equivalent. But it's still probably easier to elevate a fascial flap than a muscle flap in those situations. In terms of where your mileage may vary, people have strong different opinions about the aesthetics of them. So you can see in the bottom right, skin grafting with a latissimus flap can actually have great aesthetics. But I think it takes a long time for that to happen. And so if you're able to harvest a really thin fasciocutaneous flap, some people would argue that that is a more aesthetic reconstruction. The other thing is with the latissimus, it is on the back. So if you're taking the whole thing, you probably have to reposition the patient during surgery, which is not ideal. There's a variation called the muscle-sparing latissimus, which leaves both a functional muscle where it is, and you only need to take half of it. The other benefit is you can harvest it while the patient is supine. Now, if you're working on the same arm, it does limit the ability to do a two-team approach for the most part. You could probably get away with it, but it is a little bit harder. And you can see here, there's an intact transverse branch to the thoracodorsal nerve to the remaining half of the vascularized latissimus dorsi, but you still have a pretty big flap taken off the descending branch of the thoracodorsal artery and vein. The muscle-sparing latissimus also offers the option for free functional muscle transfer, which you can see in the bottom left. So taking the thoracodorsal nerve and connecting that to, in the bottom left, it was someone who had a transected ulnar nerve from a large gunshot injury. The other one I'd mentioned was the fasciocutaneous flaps. The workhorse is the anterolateral flap, which we've heard a little bit about. The nice thing is with these, you don't need a skin graft. The fascia layer creates a nice tendon gliding surface, which is also easier to re-elevate. There is the opportunity for a sensate flap, which is good for protective sensation. For the ALT, you'd usually coapt the lateral femoral cutaneous nerve, which you can see here. Some of the cons, though, is it doesn't fill dead space as well, and it may need a secondary surgery for debulking just to help with the contour. But again, you can harvest thinner flaps. In Asia, people are also often thinner, so that's not necessarily a problem. And pros and cons depending on how you harvest it, but sometimes you also don't want to thin your flap and sort of risk other complications. The ALT flap can also be harvested as a fascia-only flap, which again sort of has a lot of the advantages of the reverse radial forearm fascia-only flap. And because the ALT flap donor site is usually closed as a single line incision, you can actually take the ellipse of skin if you want and use that as a skin graft to really expand the amount of coverage you're providing. And then last but not least, it's important not to forget that the spare part surgery is often an option. It's an opportunity to get creative if that's what you're into, but you could sort of say that one finger's garbage is another PIP joint's is another finger's PIP joint. So it does often require microsurgical anastomoses, but it is really hard to recreate a joint. So if one is already left on the table, you can basically put a K-wire through it and restore that joint as long as it's perfused. So I know we've only gone over a few flap examples, but this table shows that there are many commonly used free flaps for mangled upper extremities. For the palm, as I sort of mentioned, you're certainly going to go for a fasciocutaneous flap to avoid the skin graft shearing. Elsewhere, it may be more about surgeon preference. So I would say despite sort of lists like this where it's pretty expansive, you may find that a smaller armamentarium of these customizable flaps will leave you golden, and at least from an efficiency and reliability standpoint. And that's all I have. Thank you, friend. Thank you.
All right. Our next speaker is Dr. Klena, who's the Chief of Hand Surgery for our system, as well as our Residency Director for the Central Region. He's going to talk about agricultural trauma in the Anabaptist community. Thank you.
Thanks. I want to take a really brief opportunity here to also thank Chris, Dr. Grandizio, for this format and for setting this up. And I think this has been an outstanding day, so much appreciated. So as Chris said, I am tasked with talking about a little bit of a different slant on this, but one that brings it back to our own catchment area. And this is considerations in the Anabaptist community. I didn't have any disclosures, but I was about to announce my new line of squalets, so I guess I have to say something in here. So upstage me on that one. Our objectives today, we talk about Anabaptist population in general and the unique working environment and the unique considerations that are there. We did have taken a look at our own population in the incidence and trauma, and then a few case examples, but we'll try not to get too overly ambitious. The Anabaptist community is a 16th century Protestant movement that came from the Reformation, and literally Anabaptist means rebaptism, and this is very, very important. Their fundamental assertion is that you choose this faith as an adult. So this has led to some of the more popular social conceptions about the Amish population with Rumspringa and their ability to go out when they're somewhere around 16 years old and spend a year out in the communities and then decide to return. But with that comes a decision to enter this way of life and never leave it. If you choose to do anything outside the order, you are shunned by your family. This does include the Anabaptist community in general, includes modern-day Mennonites, the Hutterites, and the Amish. These core values that they have are very simplistic living because the distractions and trappings of the world deviate from your ultimate goal of salvation. They believe in a strong separation of church and state, which isn't always a bad thing. And unlike most religious sects who've been persecuted, they actually believe in nonviolence. They haven't turned around and persecuted the others. So it is a very unique environment. The Amish order within the Anabaptist population is primarily in Pennsylvania, Ohio, Indiana, Iowa, and so obviously in the central Pennsylvania region, we deal with them quite a bit. even within the Amish order, there's different distinctions. So the gray buggies that you see pictured here are the Lancaster Amish, who are considered the most devout and the most restrictive. In our area, we do have some orders of Lancaster Amish, but there are additional Amish sects that are outside of the more strict variations, and we'll see that does have some implications. They believe in an agrarian lifestyle, meaning that majority of what they need to live, they produce. Community is fundamental and it's essential, but the core is the family. So as with most lifestyles and most communities where the labor you have is in the bodies that you produce, the families tend to be very big. We really won't touch on this too much, but one of the biggest issues we see with Amish trauma then are buggy accidents, where you have motor vehicles, coincidental with the cars that are on our roads. Not so much a charge of ours today. Fundamental to this is no electricity and no modern machinery. In particular, no internal combustion engines. They will use kerosene for lighting, but no electricity. They still, as an agrarian society, use equipment. So that is where the incidents of technology and trauma kind of come together. So most of their machinery mimics the turn of the century, last century, PTO generators, power takeoffs, belt drives, and this was the rise in Western civilizations of the modern safety precautions. So they have not really modernized in terms of most safety precautions. So oftentimes they will disable things that they seem to be superfluous, heavy. If you have horses pulling your equipment, you put a high premium on lightening that equipment. In the top left here, you see a thresher. Not a whole lot between the guy driving the team and the thresher, and sickles are pretty sharp. One of the more common injuries we see is a silo auger. Now this is one that's probably motor driven, but those silo augers are a source of upper extremity injuries. And really what kind of brings it all home is you see how the manpower requirements, even for something like picking the corn in the lower left image, you have 3 individuals who are in harm's way, driving teams of horses that aren't always as predictable as a John Deere. And then the lower right is an example of a belt-driven, hay baler. So you see someone, within harm's way of falling onto the belt drive and or falling into the processor for the baler. So we took a look at this in our experience as a level 1 trauma center, and the bottom left picture really demonstrates our relationship with the Anabasta population. This is my outreach clinic in Shamokin, and they have better parking than me. I don't understand that. They have devoted right up front there. And yeah, they do use it, and we have seen that. But this is an early attempt, an example of Geisinger really embracing the local community and trying to serve their needs. So we looked at about a 7-year period for our level 1 trauma center experience with Amish patients, and unsurprisingly, about a third of these are transfers from outside hospitals. And I think that that bespeaks 2 things. One, we're only seeing the more severe traumas, and they are less likely than to be not require any intervention. But also, this may be a bit of the tip of the iceberg because on the area we serve, some of these patients would be about a 2.5 to 3 hour drive away from us. So there's probably a lot more injuries that we are really even unaware of, and some of them may be treated not to the degree what we would agree with. Of these injuries, the occupational injuries predominate, so that's about 2/3 being farming injuries. About a third of those do involve the upper extremity, germane to our talk today. And even within that subset, not quite a majority, but a third of them have these associated soft tissue injuries, which Tripp had just talked about. So these present challenging patients, not just for fracture care, but also these degloving and amputation injuries and staged procedures. About half of those patients end up undergoing an orthopedic intervention, and it's almost 3 procedures per patient. So there's a lot of what we decided to call them rural myths, not urban myths, regarding this population. And one of the most predominant is that they don't follow up. And so one of the focuses of our paper was to really take a little bit of a deeper dive into that. And why might that be? Well, as with any issue with patient compliance, it's not simple, it's multifactorial. Not the least of which is they cannot drive far distances to their appointments. So in order to make the appointments, they have to contract with third-party individuals to drive them. Whole industry subsists around retired individuals who will drive vans up to Geisinger and to Danville for their outpatient appointments. There's some pretty significant cultural differences. They have an infrastructure for healthcare. I could not find the real word, for lack of a better word, they're shamans. I mean, they have medical caregivers, some of them with varying levels of education, you know, some of them with pretty impressive levels of medical education, and they really try to keep everything within the community. And not the least then are your financial concerns. I mean, it is expensive to get a driver, and it's also expensive for treatment. And so our results show that about 1 in 10 or 10% of these patients were recommended to not go home directly from the hospital and chose to go home. And we actually had 1 or 2 patients in our study. We had one who left AMA, and you'll meet him a little bit later. That's a little bit of a rarity, but it definitely happens. As far as our follow-up, the majority did attend initial follow-up, 80%, but then really only 1 in 5 or 20% would have been considered to complete their care. Looking at the billing considerations, it's pretty substantial. If you don't live in a world that has hard currency and you're presented with a $58,000 bill, that can create some misgivings about being treated all the way through to completion. So, you know, not surprisingly, the length of stay and the number of procedures is associated with the level of the bill. So are they uninsured? Not really, in the literal sense. There are strong community ties to have mutual aid programs, funds available, and sometimes these even transcend communities into state funds that they will pull together resources, and they will do public fundraising events, you know, with sales and things to try to, you know, to bolster those accounts. I think this is a pretty good story when you think about healthcare disparities. You know, I don't think the Amish come to mind as a population, but the story and the genesis of it several years ago was there were 2 individuals who kind of took it upon themselves to notice that maybe we aren't doing the best we can in caring for this community. So there were some ongoing negotiations with the church elders. You know, this was done on an individual basis. Very rarely, if when presented with a $58,000 bill, would they pay the full bill. So the negotiations would say, well, let's get you down to 25% or 30%. And in general, they were probably paying more than insured patients, you know, as a percentage of the charges. So what happened was the church elders in some of the larger regions got together, and some of the community people and some of the outreach people at Geisinger had negotiations. And this is as close as you're going to get to a picture of what happened. The Amish do not like their photographs taken. This is Hemmelwright Auditorium in the basement of the hospital, and this is the respect the church elders showed, because they do not remove their hats typically indoor, but this is the pile of the bishop's hats that were placed outside on the day of the signing of the negotiated contract. So, and I really do think it's incredible that this comes back to a couple individuals affecting a pretty profound change in healthcare for this population. And what they negotiated is their outpatient charges, they only pay 10% of all fees. So any anesthetics, any surgical fees, with the exception of professional fees, they only pay 10%. 60% of our professional fees they will pay. If they stay overnight, it actually gets better. If they're over 18, they do the diagnosis-related group for Medicare. I'm not going to spend an hour and a half talking about that, mostly because I don't understand it. But it is substantially less, and I've been led to believe by our billers that that's about 10 cents on the dollar. So sometimes it is actually important for them to understand that they may be better staying overnight. And I think most of us in this room realize that they have 1 foot out the door the first time you walk in the room. And so understanding how they're charged, which they may not really have a full grasp of, but are having an understanding, I think is kind of important. If they're under 18, they pay the medical assistance DRG, which is even less. You know, so in an overnight or inpatient setting, while their charges may go up, the proportion that they pay is less, and particularly when they're dealing with a lot of professional fees, that can be substantial. They do not qualify for medical assistance because they are not existing within the confines of the federal government in our society. They don't pay taxes, so they don't get any of the benefits. There are some unique pediatric considerations that are worth noting. The kids at an early age help out, and also, even if they're indirectly helping out, they're present. They're in the fields or in the barns. So they get unique exposures. They are not subject to any OSHA jurisdiction. These are not registered or licensed farms, so there's no checkups on any of safety equipments. They have no real interface with CPS. Child Protective Services are only involved if someone notifies them, and it's sort of a very much mutual understanding that they will be left alone unless some substantial abuse. All community dealings are done by the warden and bishops, the same people whose hats you saw there. So here's an example of a kid in a tomato grinder. How a 3-year-old has access to a tomato grinder would seem mind-boggling to us, but it's just part of daily life for them. So the first case kind of really highlights some of the issues that we were up against. So it's a 26-year-old, much like that belt-driven harvester we saw for the baler. So it's a bit of a friction injury and a bit of a crush injury all combined. The hand is burned and pulled into a pulley. So the initial, lapse in care starts with his refusal to have an expedited, trip to the hospital. Not even an ambulance, much less a helicopter ride. This is calling the guy who drives the van to bring him to Geisinger, because that costs about $75, not $5,000 for a ambulance ride or $75,000 for the helicopter ride. In spite of the fact that he had initial debridement immediately upon arrival, and you can see an associated dorsal soft tissue injury, tendon loss is very much similar to some of the cases we've seen, within 24 hours, a foul odor. So I think you had mentioned you're not allowed to pimp anybody. I think I am allowed to. So Andrew Cross, you're on my service. So are there any considerations when you see this patient initially in the emergency room that may be a little bit different than what you would expect for a standard industrial injury?
Yeah, on farm you want to probably add him a penicillin.
Because for right, anaerobes, so Clostridium. So absolutely, these patients get old school penicillin run for the anaerobes that are present, and particularly for Clostridium. And that's the stuff of the old Napoleonic Wars and lockjaw and tetany, and we see that at Geisinger. We see patients who have to be placed into a dark room because any stimulus results in just horribly painful contractions because they are not big fans of vaccinations, so they were ahead of that curve. So the initial debridement on arrival, take back in 24 hours, foul odor, infection, repeat serial debridements over 3 days, even with temporary stabilization, just not further insult to soft tissue envelope, infection. So, long discussion. We already just heard from Trip. This is a pretty good slam dunk for a local pedicled radial forearm flap. This is not a difficult problem for us to solve, but he has to be accepting. He was not. He left for the home remedies. What was that? He came in with, this was my first experience with a little tin full of beeswax, the famous burdock weed. He was putting just basically a local salve on this. And you can see it's pretty incredible what the human body can do. I probably wouldn't have seen him back here on the right-hand side, but he wondered what that thing was that was protruding out of the wound, which was a substantial portion of the metacarpal. After we removed that in the office, never saw him again. Functionally, you can imagine this is pretty difficult. This is not what I would consider a triumph, but this is, sort of a testament to the barriers that you have to get through in talking about a global period, 90 days, no further charges. And I think we have a responsibility to make sure we have those conversations. One of the reasons I work at Geisinger, as Dr. Parenti likes to say, we're not businessmen. So we do have to get involved in these conversations. As an alternative case, here is a 47-year-old male who is working for the English, not in a non-Amish capacity, in a sawmill. This is the chop saw that did this damage to him. So he falls under workers' compensation. He has insurance, and even while a lot of his family members were, advocating that he just simply complete the amputation on this, we had a pretty long discussion, and he decided to go for limb salvage. Primarily shortened some of the tricks we talked about. He had intact ulnar artery and some perfusion distally. Revascularization, limited techniques on the ulnar side to try to not cause further insult, the use of an X-Fix for compression, and ultimately achieved union, returned to work, good functional outcome, and was very happy that we kept his arm. So the difference there is you're dealing with someone who falls more under traditional insurance roles, and money and financial responsibilities were much less. So in summary, I think what we're, to bring it home is, every patient's unique, but I think in our catchment area, this is most certainly a patient population that has different cultural, financial, and even the manner in which they're injured, considerations, and I think this is one of the few triumphs, and Geisinger's not really interested in making this publicly known that they are giving discounts, but this falls under, fellowship and being a good neighbor, and I do think it's kind of important that we understand that. So, all right, thank you very much.
That was fascinating. Thank you. Our next talk will be on prosthetics and rehabilitation after upper extremity amputation. Jamie Watson, one of our certified hand therapists in the central region, so appreciate you joining us, and from there.
I have to use this thing. So again, like everybody else, I want to thank Dr. Grandizio for inviting me here, putting some spotlight on the role of therapy after injuries like this. We have a great group of us with a great group of surgeons and residents. We all work together, so it's a really cool experience. So I click here. Yep. No disclosures. Did my objectives not come up? So there's over 500,000 individuals in the U.S. with upper limb amputations, and I believe it was talked about before that this is expected to double by 2050. Patients with upper limb amputations tend to be younger compared to lower extremity amputations, and 70% of them are traumatic events. So this is important. We've talked a lot about planning with prosthetic teams, with therapy, with, talking about length, but a lot of the upper limb amputations are actually coming from a traumatic event, often with farm equipment or from factories, and, they're coming into an ED. The lower limb amputations are more likely caused by vascular dysfunctions, and so that can kind of be discussed over time and planned with lower extremity the prosthetic team. So the other thing that was touched on before is the reported rate of abandonment for prosthetics. For passive prosthetics, it's 53%, body powered or mechanical, it's 50%, and for myoelectric, it can be 39%. So types of prosthetics, passive, body powered, and externally powered. The factors to consider are lifestyle and goals, intellectual and cognitive ability. We'll get into that with the myoelectric. Cost and insurance coverage, durability, how much does a patient want to come in for prosthetic fittings and changes, and where the amputation is, and then of course the skin integrity of the amputative site. So for passive, these are used more frequently for distal hand and finger amputations. It increases the functional length of the amputation and can help people with like posting. So for our distal fingertip amputation, especially index and thumb, just giving that extra, few centimeters can actually really help with their function. They're highly customizable for skin tone. I've had women who want it just to kind of have like that nail look. They're technically lighter weight. They can be very expensive because of that detail, but 3D printing has the chance of decreasing that in the future. So the nice thing about Passive as well is that they have different positional options like ratchet, locking, friction, and link joints. So the picture shows a gentleman who has the ratchet positioned passive prosthetic. The problem with these is that it does require the other hand to bend it to the position you want and then also to release it. So the patient would take his opposite hand, put it in the position he wants it, do what he wants to do, and then he would have to use the other hand to bring it to the terminal point where it will release. There are also some buttons that you can push on the dorsal, what would be MP joint. Some of them can be super finicky, and like you could put your arm down, it will release it. So, kind of going over, with a lot of my patients, we have the ability to go to hanger, which is where the prosthetist is, and kind of go over what the patient's goals are right there with the prosthetist, and talk about some of the different patient goals and what would make the most sense for them. So that's a really great thing. These also have about a 70 to 80% or pound ability. So for like dumbbells, this is a really good option. So body power devices, examples include MP and PIP drivers, of course also with the shoulder harnesses as well, but I usually work with more of the hand. Good for fine motor control, moderately priced because they are lighter. One thing I will say about this is that the motion and the strength is highly dependent on the proximal joint, and we'll get into that. And they're highly dependent on skin and mobility of the proximal joint, so motion equals motion. So this gentleman here had necrotizing fasciitis in surgery that he ended up with an infection. He was a 4-limb amputee, so he lost both of his legs and then obviously multiple fingers. And when he came in, he had had skin grafts on both of his upper extremities, so we really had to work through scar adhesions to get the MPs to bend enough for him to even qualify for these. I did have some videos on here, but they must not have been loaded. So externally powered devices, most commonly the myoelectric controlled. So it detects EMG signals from large muscle groups in the residual limb. So there's a dual site control versus single site control. Dual site is where you take one muscle group for flexion and then one muscle group for extension. So most commonly, is the wrist flexors will make the fist, wrist extensions will open it up. For patients who aren't able to isolate that, you can have a single site control where wrist flexion will close the hand, you'll wait a beat, and then wrist flexion again will open the hand. You can also set a lot of these to be a timer, so if you contract the muscle for 3 seconds, it'll bend. If you contract the muscle for 3 seconds, it'll extend. Multi-site control is where you have more than 2 muscle groups that can control 2 articulating joints, for example, the wrist and the hand. This is harder when you get more distal because there's less muscles and skin to get the EMG signals from to have those contract. So there's a lot of benefits. The grasp can be really strong. The other thing is if you if you hold it in a position, you can actually turn the device off and that'll lock it so that patients can hold things without worrying about opening them. Many of them have adjustable wrist position, so you can extend, flex, and hold it in that position. The threshold, the EMG thresholds can be modified. So if they have a really strong extensor contraction that's getting in the way of the flexion contraction, you can actually lower the threshold so that it doesn't counteract. This comes in really important later when we talk about like, trying to hold something and lift it without engaging your wristic sensors and dropping something. That's a lot of our training with OT. There's a variety of different finishes. It is water resistant, but not waterproof. Some of the challenges with the myoelectric devices is that the technology can be finicky and you really need to have a good grasp on technology. I had a 70-year-old patient with a myoelectric device, and luckily she was very in tune with her iPhone and could do all these apps. Somebody else might have a hard time with that. And then you're definitely not looking at like the Amish population using one of these. They are expensive and they require quite a bit of upkeep. Sweat and skin integrity can impede the EMG signals, and that's something you don't find out until after you've already fit the device and you're trying to wear it. So the other thing is loss and gain of body weight. So a loss or a gain of 10 pounds will significantly affect the fit of this and can make it either really uncomfortable or it can make it too loose. And I did have a gentleman that, when he would walk, it would almost slip off, and it's a heavy piece of equipment. So the picture on the right is a myoelectric device, and she got a terminal device for it so that she could ride her bike. That was really important to her. And then So some of this is kind of trial and error. We find out what pinches, what grafts, and what fists make the most sense for which activity. And then you can program the device to switch between those with buttons. So like if you say like, okay, my most commonly used ones are lateral pinch, 3-jaw, and a fist, you can program those to be your favorites on your device. And so if she's like, okay, I want my 3-jaw chuck, she can click to that, and that's the fist that will work. So residual limb care and treatment goals, when we get a patient, we know we're going to be training for prosthetics. We have to deal with wound healing, desensitization of the nerves, pain management. Some of the myoelectric devices, because or any really prosthetic, is so close fitting. If you have a residual limb that is super sensitive, you are going to have a hard time with pain management in the prosthetic. And then of course motion of proximal joints and the strength of proximal joints. So for patients who are planning on getting a myoelectric device, they can weigh up to 10 to 12 pounds. And so if you think of holding a 10-pound weight and carrying that around with you all the time, you have to think about, your shoulder strength, your back strength, even gait training, because it's going to make you imbalanced. So we really talk a lot about that. We work with patients, and even at some point after, we get them into PT to help with gait training. So once a decision is made on the prosthetic type, prosthetists fit and review wear and care. Myoelectric thresholds set for EMG signals for most predictable responses. And modifications made for skin integrity and irritation worked out over time. So when we get patients that come in for prosthetic training, a lot of it's trial and error, and then going back to the prosthetist and saying, this device works really well for this and this, but the patient has a goal of lifting weights and they can't do that because there's not enough strength in that prosthetic. So really being an advocate to the patient as well, because they might say, well, I just won't use a prosthetic. And sometimes that is the best option. But if there's a different prosthetic option that can help them reach their goal and make what they do safer, then we should definitely be going to the prosthetist and making a plan to advocate for the replacement or talk to insurance about coverage. With the myoelectric, a lot of it is controlling input. So, we crushed a lot of styrofoam cups with some of my patients with the myoelectric devices because they have to sense when to stop. If they're not hitting anything hard, the device obviously doesn't have a sensory input. So it will actually crush anything soft. So kind of controlling that. And then you have to look at, we did a lot of like lifting. If someone's lifting let's just say like a baking sheet, and they're lifting it up, to not engage the wrist extensors to open the hand, you have to control that. You have to be thinking about it all the time, and it's stuff that we do and just kind of don't think much of it. So practicing tasks like that and seeing if there's different ways to either lock the device in a certain position for safety so that they can use their other hand for more fine motor tasks, and just really going over different scenarios and seeing what works best. So the patient that I had, this guy, so he had the body-powered MP drivers, and the distal pieces of these had no ability to resist anything. So that was something we went back to the prosthetic company and said, he can't lift weights. He can't hold anything, because as soon as it rolled out to the distal pieces of that, they actually would open back up. There was no way to increase the tension of them. And he most recently came in he got new passive ratchet prosthetics that he could lift weights with. So thank you. I think that was all.
Thank you, Jamie. We talked a lot today about collaboration and multidisciplinary care for a lot of these injuries, and I cannot emphasize enough how important it is and how beneficial it is for patient outcomes to have our therapy colleagues in clinic with us, seeing and evaluating the patients, not only for the profound impact I think they have on patient outcomes, but for our education from the surgical side of things. So thank you for that talk and for your role and everything for patients. Thank you. We are going to take a brief 5-ish minute break while we set up for the case discussions and then Q&A. So we'll try to come back here around 11:10 and get started. Come up to the front. We're going to get started with our final two sections here.
Just make an update on how people can get their safety credit. So it looks like nobody actually registered. So they're going to get an email. So I just need to say something about that.
What do you...
So basically, everybody who signed, their names will go to people, and then they'll just get an email. They have to click the link in the email, which will take them to evaluation.
I'll just do that right now.
Perfect.
All right, just a brief announcement before we get started. Anybody that registered or signed into this will get an email for CME credit. There's a link that you can fill out, and that'll happen at the conclusion of the course, so just keep an eye out for that. I want to introduce Dr. Dwyer. He is one of my hand and upper extremity surgery partners in the central region, and he will be leading our interactive case presentations for the next 15 minutes.
I want to start off by first thanking the course organizers. Dr. Grandizio, thank you for the invitation. Of course, our guest speakers, our founders, and Dr. Parenti. So thanks for having me. The charge for me this morning is going to be talking about a couple cases here, some non-union bone loss cases that I heard. Well, I wasn't here in the beginning, so I didn't hear the message about no pimping, so I think I should be good for the interactive cases here. No relevant disclosures for me. Objectives, obviously just going over some cases, looking at bone loss, non-union, and reviewing some treatment alternatives. So nice thing is for folks in the audience, you had some great talks earlier, so this is going to be kind of immediate feedback, see how much you guys retained, because they went over a lot of this in their excellent talks. So they were helping you out, they had you guys in mind. First case is from a colleague of mine, Dr. Sandilands, down in Florida. So I thank him for sharing this with me. 35-year-old male who presented to his office about a year out after a motorcycle crash with multiple injuries. And then his patient's primary complaint is his right upper extremity with these films. So the first question for the audience, I guess, is what else do you need when you have a patient coming in with these images? And I'll hopefully ask residents to chime in. Labs, yeah, so definitely labs are going to be crucial. And what's the thought process for getting labs? Perfect. What else would you want to know about that maybe doesn't show up necessarily on these films that we talked about in some of the other talks earlier? Soft tissue, is there satisfactory, appropriate coverage for here? And then the other one would be neurovascular status, so just a kind of a complete exam of the upper extremity. So these are his films. Labs were done. Those look normal, so kind of we're planning on surgical treatment. Any other steps or plans moving forward in preparing for treatment for this individual? Some people will talk about getting a CT for better visualization of the fracture. Again, evaluating neurovascular status, looking at is the radial nerve going to be something that you want to have good, clear documentation ahead of time, as well as postoperatively as well. Treatment options. So we have a midshaft humerus fracture, non-union, previously treated with intramedullary nail. We had a great talk on this earlier. What are some treatment options that we could consider for this?
Nail removal and compression plating, bone grafting.
Compression plating, bone grafting, very good. Any other good ones?
Do an antibiotic spacer and maybe like an SLA technique?
Yep, induced membrane with the antibiotic spacer, Masquelet technique. Anyone want to do lengthening osteogenesis? Could be fun with a big X-Fix and have some good time. One that I think is reasonable, we'll kind of show here next, is similar to obviously opening it up, debriding it. Very important to get rid of all the kind of fibrous tissue, clear out everything that's preventing your union, the callus formation there, getting cultures at the time. Very important to even debride back to healthy bone. You want kind of bleeding bone, so you can even take some of that. So in a way, doing a shortening procedure, as was mentioned, you can shorten the upper extremity without significant deficits. Cannulizing the canal to get some endosteal bleeding, and then compression plating. And one of the kind of tips for this is you can compress by technique with your screw and plate as you would standardly do, and then you can also do that a second time over to kind of what you would say double compression. And you want to have extra cortices, one extra set of cortices that you would normally do for a standard fracture for fixation to get that bony stability, that compression for hopefully healing and early motion and function. What are things that you could add to your fracture site to help with healing? Perfect, bone graft, and there's, you know, osteoconductive, osteoinductive. There's a multitude types of grafts, both autologous and allograft, to help that regeneration. So patient did well with surgery. 3 months out, you can still see a little bit of that fracture line. No complaints, still no issues with his radial nerve, which was documented throughout, including in the operative note. And then at a year has solid bridging across his fracture site. Comments from the front of the room about case number 1? Anyone want to add anything that I missed or thoughts?
I mean, I think it was obviously well done. I think that, decision-wise, posterior approach and posterior plating, I think is a very nice option for the location where the fracture was versus anterior lateral. And then I think, as you mentioned, just making sure that you're getting really good compression, through the dynamic holes. And you can do that as many dynamic holes as you have. You can keep doing that all the way down the line. Or in addition, using something outside the plate, right? So whether it's a articulating tension device or sort of a poor man's version of that, with a bruise and a screw. Or I also like to sort of break out the pelvis clamps and just use two-screw technique and clamp it down with a, whether it's a Farabuff or a Young Bluth or something like that, that just, really gives you quite a bit of compression that you can get at the fracture site.
Awesome, thanks. We'll move along here to case number 2 from a colleague of mine out in New Mexico. 45-year-old male, gunshot injury to left hand, high velocity, close range, important considerations for this patient. Yep, so definitely open wound coverage will be a concern, which actually surprisingly for him had a decent soft tissue. I don't have initial films, but the soft tissue coverage not a major concern. Neurovascular status, function of adjacent soft tissue, including flexor tendons, extensor tendons, and then contamination if there's any concern for infection. So clean wound, satisfactory soft tissue, and other next steps that we need. Do we need any other imaging? Do we need any other lab work? Probably not. What are our treatment options for this first one?
So the long ray, you can probably fix with a metal screw, like you previously showed. I think the index and the carpal, you could potentially provide an allograft, strut graft, or interposition graft, or just put a pin in it, but there are a couple pins in it to allow secondary bone union. The soft tissue, like you mentioned, like tendon fixation or tendon repair, and then neurovascular repair, obviously.
Could I just add something to that second? So this is in Albuquerque, so I think one of the questions you ask yourself, is this from the city? Did this occur in the country? There's a lot of Indian reservations out there, and they're not necessarily the cleanest places. They're kind of similar to the Anabaptist population. So we have those answers.
Great consideration, and I would say this was more of a urban wound rather than kind of a rural setting, if that answers that question. Okay, so just as you had said, intramedullary screw fixation for the long metacarpal, not a lot of bone loss there. That's not really kind of the main one that we're going to be talking about here. Is really going to be the index finger. You can see when they line it up with the kind of appropriate cascade intraoperatively, there is that bone gap there, roughly 2 centimeters. And so talking about options, whether it's allograft, vascularized graft, or autograft, chose to do iliac bone crest graft here, harvested that, and then we're able to use intramedullary fixation to capture that for stability, minimizing trauma to the surrounding soft tissue to allow for that early active motion. These are the patient's films at 3 months, did very well. You can see the bridging bone across, and these are the patient's clinical images at 3 months as well, demonstrating good coverage, soft tissue, and satisfactory motion and mobility.
If you go back to the post-op, just a personal gripe on things here. It looks great. I mean, everything healed. I would throw up a cautionary flag on the use of these intramedullary devices. They're great, but those are very deep and buried, and you've left, not you personally, but one left a lot of room there for fracture beyond that, which could complicate anything. If this guy's already significantly up on the knucklehead factor, either self-inflicted or having been inflicted upon, I would just caution a lot of people, that those implants could create some real problems down the road.
Do you lean more towards doing K-wire fixation in this type of setting where, hey, I can
Might leave
remove
them a
these in
little
case
bit
there's...
more accessible distally, and also not leave that segment of bone. I know we have to listen to the trauma guys, sorry, Ken, talk about this all the time about, basically leaving stress risers. It's not really an intrinsic stress riser, but the ability to get a neck fracture distal to that down the road, and then implant removal. I've already seen a couple of these that have been bent or broken, so that would be my concern, just as a cautionary tale for everybody in the audience. These are great, and they've changed a lot in terms of the outcomes, because you can move these people very early, not necessarily in this circumstance, but that gives me agita.
Yeah, I agree with you. I think first seeing these films, you can see how deep that would be, so very difficult in case you did ever have to retrieve it. Obviously, the question of K-wires, which can be easily removed in case there's concern for infection or issues versus plate and screws, but which has maybe a little bit more dissection involved, a little bit more scarring involved, but definitely getting the full bone coverage, I think, is an important point. Yes?
Does anybody worry about doing definitive fixation in the initial surgery where he might have his own injury that's not fully declared at that time, and then, potentially having to go back and debrief because, it got worse over time?
Yes. That's a good point. I mean, the x-rays don't show the soft tissue, and so that should be the number one consideration of how you progress with your fixation. On the soft tissue side of things, I was going to make a comment also, just when these blast injuries in the hand, they develop significant MP extension contractures. And it's a decent result actually, but there is extension contractures of the MP joint, and that's the shape. Am I allowed to ask the questions or no?
You please.
So my bow tie brother right here. Why do MPs get stiff in extension?
I would imagine it has to do with the intrinsic or extrinsic tightness.
Okay, and anything about the shape of the joint?
Yeah, the cam deformity, so as the phalanx goes over the metacarpal head, lengthens the collateral.
Yeah, so the MP is like the knee. It's like the knee joint of the hand. You know how the femur has that trapezoid, and it's see, hand surgeons know ortho. So like the femur, it's more narrow anterior than it's supposed to. Same with the metacarpal head. So my one maybe tweak would be to try to either splint or pin those MPs flexed at that initial time, just to prevent those MP extension contractures. Because the more that MP can flex, the more function you'll have of that hand. And then a corollary to that is, these guys can all attest to it, is oftentimes if you forget about that, you're then playing catch up at subsequent surgeries, and you try to flex them down, then you create a dorsal wound. So the more you think about that in advance, if you flex the MPs, you'll keep nice, soft, supple skin on the back of the knuckles. So it's just one thing.
That's why a lot of us will harp on that intrinsic plus position for your splints, casts for patients when they're being immobilized. Great point.
Yeah, I think another small tip about the Intrinsic Plus for wounds like this is when you're putting the plaster on, you just put everything on dorsally. So when you put any plaster on the volar side to get them in Intrinsic Plus, it innately stops for the MPs from going down a little bit, unless you have it like perfectly contoured. So if you just put all the plaster on dorsally, it's good. But to the comment earlier, yeah, it would have been helpful to see the soft tissue defect at the beginning. But Scott Mitchell, who's one of TRIP's fellowship faculty, has this good publication on doing Mascalaise for basically all gunshot wounds in the hand, because they are kind of dirty wounds. A lot of times, depending on the caliber of the rifle, it can have a big soft tissue defect. And to me, it seems a little bit safer. I mean, this obviously turned out great. I probably would have done a Mascalaise technique for this.
They have also come out with a IM nail that has like the crossing screws, which, because for this I would worry about some rotational instability. I don't know if that was a compressive screw as well.
So, yes, so there are products coming out that are like a locking nail with locking screws that can provide that extra stability, especially good in patients where there's bone loss, which this would be a reasonable candidate for that. There are also studies showing that a lot of the intramedullary threaded nails and screws like this one, if you capture enough of the cortices, it actually can provide satisfactory rotational stability. But yeah, no, great point. And then to your guys' points and questions, I have another case which is from a former co-resident of mine, which is, you guys kind of, I don't know if you looked at my slides ahead of time or not, but a 26-year-old right-hand dominant male who had a gunshot wound. There was, I think, a delay in the patient getting to this individual, and there was concern a little bit more about debris, infection, and so kind of to your point, imaging here, radiographs, the big issue here is the ring metacarpal with that bone loss. Not only that, even though the soft tissue impact doesn't seem too severe here, sensation deficits about the adjacent finger, but able to flex and extend the digits. So, other thoughts or questions in workup for this patient, and what would maybe help you make decisions and what to do other than what I've alluded at already? If not, we can cruise through because I think you guys crushed it already. So wash out the wound, thorough irrigation. Again, you can get cultures if you want. Inspect surrounding soft tissue, looking at flexors and extensors, which were intact, as you can see here. Repair of the common digital nerves was done. And due to the concern, as previously mentioned, plan was for induced membrane Mascalaise technique. So provisionally fixed with K-wires using the adjacent metacarpals to secure the length, rotational stability, and position. Antibiotic impregnated cement wrapped around a K-wire to maintain its position within the canal of that ring finger after kind of debriding it out to kind of form that shell, trying to kind of create smooth edges between the bone and the cement. Those crossing K-wires removed around 4 to 5 weeks to allow patient to begin working on motion. And then at 2 months, wound has healed nicely. You can see the solid position within. So at the 3-month mark, went back in through that same wound dorsally to avoid the trauma to the the digital nerve repair. And you can see an image here with the capsule surrounding that cement, which was peeled away, creating that cavity in the top right of your image, which was filled with cancellous bone with the bridging plate across. these are the images. You can see some of that cancellous bone filling that void and the fixation there, which at 3-month mark looks pretty solid, impressive. And then this is patient at the 3-month mark as well with a healed wound, satisfactory extension. You can see just a hint loss at flexion, but really phenomenal outcome and doing well with that. Cool. Comments?
Did they remove that plate later?
So at the time of his patient's last follow-up, it had not been removed. I think they were talking about removing it because they did bridge across, as you can see, the CMC joint just to provide a little bit further stabilization. But I'm pretty sure this patient has been lost to follow-up. Other comments, questions about this one?
Bridge plate of the carpus, I think it can be a very effective technique with induced membrane, particularly with that short segment in the proximal end. And I think if you discuss it on the front end, it's oftentimes too an opportunity when you remove it to go back into a tenolysis, which pretty often some of these can require. So thank you. As we conclude here, we're going to do a question and answer session with the panelists about any of the talk topics or things related to limb salvage, non-union. I'll just remember to go up to the mic for questions, and while somebody's going up, I'll start off. But I think we've come up in a few different talks and presentations, but I think a fairly common complication that we all see with these are infected non-union, particularly after an initial fixation in some of these cases. I'd be interested to hear thoughts on single stage versus 2-stage revision for infected non-union. I know there's certainly considerations by region and certainly some conflicting literature, but I'd like to hear from any of our panelists about how you think through that decision making with a 1 versus 2-stage procedure, whether that's the hand or the humerus.
I'm happy to jump on that one. Thanks for the softball. I think a lot of it depends on the location, the local soft tissue bed, the vascularity, and your likelihood of healing. The patient has a big, part of it, meaning are they going to follow up? Are they going to be smoking 2 packs a day? Are they going to be leaving for Rumspringa in a couple days or whatever? So I think with the humeral shaft, I'd love to hear what you have to say, but I think that does lend itself to more aggressive approaches with 1 stage and being really aggressive with your debridement, which I think is probably the most important thing, and having a good plan for reconstruction. In the hand, if we're talking about infected non-unions, I think the soft tissue dictates what you're going to do. I mean, you usually have tendon injuries, nerve injuries, and so I think just good orthopedic principles of eradication of infection, maintaining the hand in a functional position as you heal, and then I probably would, if the more soft tissue involvement, the more likely I would be to do a 2-stage approach, if that makes sense.
I agree. I would add, in things like the humerus, I don't always commit to that decision prior to surgery. And I would say, as an example, if somebody that's had maybe a long posterior plate, infected non-union, radial nerve revision dissection can be long. And, to really safely do that, remove the plate and do a debridement can be a really long procedure. And I think if you're looking at like 2.5 hours before you get it out, and then you're talking about a revision, I have no problem saying that I'm not doing my best work, 3 hours in there. And cases like that, I'd have a pretty low, low threshold to stage. So I think those considerations too, especially higher up in the humerus when you're dealing with, revision, radial nerve dissection, or certainly around the elbow when you're carving nerves out of scar for the first half of the case. That for me can dictate a little bit of the timing of that as well.
Yeah, I think that's where it's challenging, right? Because it's also the more times you're in there, the more challenging it may be to dig out the radial nerve too. And so I agree. I don't necessarily commit to the 2-stage I think some of it depends on what you find when you're in there. And I also think it depends on the lab workup and how suspicious you are of the infection. I mean, there may be times where you're doing a one stage and then it turns out that the cultures come back after the fact and it was infected. It may not have appeared infected, maybe the labs didn't show it. And so, in a sense, you're doing a one stage just by doing your sort of debridement of the non-union site and putting a plate in and then finding out later that you're also dealing with infection versus something that's, grossly infected, there's pus. I think in those settings, I think it's more obvious to do a two-stage, do an antibiotic spacer and come back and then, feel more comfortable with your definitive implant, being in the setting of something that is clean, right? The bottom line is you have to debride it effectively enough for it to heal. And if you don't get control of the infection, it's not going to work. And so I think you're trying to manage all those things, safety around the nerve, number of operations for the patient, but also ensuring that your surgery has the best chance of success.
Lou, would you have to use an external fixator during those two stages to maintain length or stability, or just a splinter there?
I think it depends on the timing. If it's something where you're not going to be back for a while, there may be some advantage of like some provisional fixation just to keep length. But if you're just waiting for cultures and planning the second stage, I wouldn't say it's a never and always. It may be very case specific.
Yeah, I was wondering the feeling of maybe Dr. Corey for non-union that you deem maybe not infected, hypertrophic. What are you feeling on doing a bone marrow aspirate from the iliac crest and on the X-ray screening, infiltrating that non-union with that aspirate, without, especially if you have like a solid fixation. I know you have alluded to if you have a non-union, even if it's hypertrophic, to revise the fixation. But what are you feeling instead of revising the fixation, whether it's a plate or a nail and it looks solid, just infiltrating the area with the bone marrow aspirate of about, say, 5 mils?
Yeah, so I think the challenge with the hypertrophic is that while the fixation may look solid on X-ray and maybe there's no signs of the hardware failing yet, it's clearly sort of shown that it's not stable enough, right? Because the biology is there for hypertrophic. It's just that the stability is not adequate. And so that's why I think that the literature would show that the hardware needs to be revised.
No, what I was saying, a hypotrophic.
Atrophic, yeah.
Yeah.
Yeah, so even with that.
Put it in the biology without putting it.
Yes. So the challenge with that, there's also a paper that suggests that there's an increased failure of that without revising. And not revising the fixation was an independent factor in increased failure rate. And so, I think the challenge is everything could look fine. Yes, it's atrophic. We think we just need to add some biology. But that metal has been stressed and fatigued by not having the healing. And so I think you're set up for it to not work over time.
Have bone stimulators fallen out of vogue in the last few years?
No, you still can. Yeah, you can still use those. So, right. So that's you would try that first, but if it's failed that, then I think you're. Yeah, I think and there's also literature suggests not just in the humerus but in general, right? If you have an atrophic non-union and you have a vitamin D deficiency or some other endocrine abnormality, just correcting that can allow it to heal. But sometimes you run out of time, right? You lose the race between the metal failing, and so that's the challenge.
I had a question for Jamie, actually. Have you noticed in your work with upper extremity limb loss, have you noticed any trends or characteristics of patients who tend to do better versus not? Because, as a hand surgeon, sometimes, someone has a bad injury, they disappear, they never go to therapy, and they come back and they're perfect, and you're like, what are we doing here? And then with the prostheses, a lot of it is the training, the understanding. So I would love to hear if you've noticed any trends.
You have this thing. Oh, I'll hold it, thank you. So I have seen more compliance with my workers' comp patients, and I think it's because if they're not compliant, then they kind of lose coverage. A lot of my patients, what I will say, the more high-tech or fine motor, they end up just using blunt force of like the remaining digits. My prime example was the one patient who had the MP drivers who then went to the passive ones because the things that he wanted to do, which is similar to the general population that I see, is more like heavy lifting, weightlifting, not as much of the fine motor stuff. The more basic it is, the more that they tend to just stay with it, I found. A lot of our patients, the Amish community, again, they really don't want the frill, and they basically just function without any type of prosthetic.
So I was going to ask, obviously the Amish may not use a myoelectric. Will they use any prosthesis?
Not that I've seen. And the one picture didn't come through on the latest version of my presentation was an Amish gentleman that I saw after a free flap for splinting of his wrist to maintain that position, lost all of his digits. He had a little bit of his thumb left. And, you know, I kind of started talking to him about it, and he's like, I'm going to go home. He's like, I have 7 sons. And I was like, okay. Like, and that was his answer. And so they just really are not interested in anything that is not just, I'm healed, I'm done. Did I answer your question?
Yeah, absolutely.
Okay.
I know Chris talked about this, but I would also put a little emphasis on it. You know, we talk about the things that OTs do. They do splints, they do range of motion, but they put therapy in hand therapy. I mean, this is your first line of defense, and I think we are spoiled. There might be a contrast between the two programs, but having embedded therapy, they are the first line to come to us. You know, it all falls under the bucket of poor coping mechanisms and poor coping skills, but I don't know how many times they will come to us and say they're a mess. You know, we've had patients who distal radius fracture, first post-op visit. I can't function. I got out of bed today. I went back in bed. My daughter's a senior in high school. She's going to graduate in 6 months. I don't know how I'm going to do my laundry when she's gone. I'm not sure I'm going to be able to cook. That's poor coping mechanisms to a T. She hasn't even had her stitches taken out yet. You know, we're just working on initial, hand, MP and beyond motion. So, I can't emphasize enough that we are spoiled, but if you are in a private practice in a community and you don't have an embedded OT, you better have a good relationship with them because they are spending more time with them and they are giving reassurance and they are reaffirming the messages. I mean, how many times do we do that? We just make sure we're on the same page with the messaging. You're going to be fine. It's going to be okay. And that's where you start with, I can't get out of bed today. You know, it's like, your daughter, in 6 months, you're going to be doing anything you want to do, and then that message.
A lot of hand therapy is above from there.
Yeah, that's very true.
I'll say I do not have embedded hand therapy, and it's a big disadvantage, I think. But one of the ways I've made it work is we still do have a great relationship with our hand therapist, and we talk to them all the time, and they will still see the patient first. Like a distal radius fracture, for example, they'll take off the surgical dressing, get them on the thermoplastic splint. It makes my first visit a lot easier. I'm not sitting there taking off the splint, but they also have already started doing some range of motion, and I can emphasize it and work well that way.
These patients that you're doing these reconstructive procedures on that had prior wounds and infections, are you ever giving steroids to facilitate movement, or do you preclude from that? I know we use it often in the traumatic setting, but in the setting like
So he's throwing a shot across our bow because we throw Medrol dose packs around like it's a Tic Tacs, so yeah, and then we have a secondary high dose, but I'm interested in your experiences.
Yeah, I had not done it for a while. John Bass is one of the guys I work with, started giving it for everything, every fracture, every whatever minor procedure. And the patients do seem to get better. So I've only recently started doing it. I don't do it super aggressively, but it seems like it makes a difference. I wish there was more data on it.
I'm a little more hesitant. I only give it in the setting of if I'm worried about like HO. I find that it helps them mobilize a little faster, but I can't say I'm a big adopter of it. Maybe I should just try it.
I'm a steroid evangelical. For most paraarticular elbow trauma, I give them 10 milligrams of IV dexamethasone intra-op, and starting post-op day 1, a Medrol dose pack. There's some clinical series that have shown impressive improvements to the extent of like 20, 30 degrees of flexion extension in the elbow. I started doing that without mentioning that to either of our hand therapists who work routinely with elbows, and they were both like, hey, the last couple of these elbow fractures don't seem to be as swollen and miserable in the first 2 weeks, and I think they thought I got better at surgery. Turns out it was just steroids. I will say, anecdotally, I had some concerns, regarding infection. I obviously don't do that in diabetics. I have not seen that has made a difference, so I would say I fall strongly in favor of steroids for all.
You do 1 dose intra-op dexamethasone, then you do a Medrol dose pack.
Correct.
Starting
Post-op day 1. And turns out, and for most of these procedures, they're giving patients 4 milligrams of IV dex anyway, whether you know it or not, whether they're diabetic or not. Just give them 6 more.
I think part of the reason I've been more okay with adopting it is I still do some mandible fractures every now and then, and that, ever since I've been an intern, is routine. I mean, we give 8 of Decadron times 3 before they leave the hospital routinely and give them steroid afterward. And we always thought of it for airway swelling, but it probably helps everything and doesn't seem to affect them too much.
Speaking of things that are kind of more down the line and things that see us more than we see them, how are you managing shoulder-hand syndrome and CRPS in these patients?
Oh, that's me. I was like, that's a good question. So a lot of it was graded motor imagery. Kind of got big, I think around 2005, 2006, mirror therapy, imagery, left-right discrimination. The buy-in with that is super tough because you have patients who are so frustrated and they're so emotional, and you come to them with big words like the homunculus, and you're trying to explain to them about how the part of their brain that represents their left hand is, just not receiving the correct messages. And then they're like, well, you said my pain is in my head. And I'm like, no. And they can get pretty defensive because they feel like you're blaming them because they should be under control of it when it becomes this centralized system. And you really have to get them to buy into it. That's the hardest part of CRPS, graded motor imagery training. So we really approach it. We start with left-right discrimination. There's actually apps now on their phone that make it a lot easier, and they can actually track progress and how they improve. We've actually started using very light taping if they're not having any adhesive allergies, to do just that input into the skin to normalize the input and get that body to stop reacting as every external input is a pain response. We use vibration to more proximal nerves. And we try to really encourage motion under the pain threshold to, again, retain that positive feedback loop into restoring that part of the homunculus that is getting the information from the limb. There is a cocktail that you will sometimes prescribe to help in the early stages of it. Medrol dose packs are used. Basically, we just really try to say, do what gets that arm to feel good so that they can move it and continue that domino effect of the more use, the more input, the better the nervous system.
Yeah, I think therapy is obviously the mainstay, as she kind of went over, but communication, getting the patient kind of on the same page with understanding. And then, as these guys were talking about, I'll do a steroid, and an anti-inflammatory, vitamin C, even in SSRI. There's kind of a little cocktail that I'll throw at these patients to kind of kick them into high gear and get them over that first speed bump, that seems to make a difference.
I'll just make a quick counterpoint. CRPS is a real entity. It is wildly overdiagnosed. I think you need to be very cautious when you label a patient as having CRPS. There's clinical series where there's no identifiable nerve injury. They received a diagnosis of CRPS or a chronic pain syndrome. They get an isolated carpal tunnel release and their hand function returns, essentially to normal. There are certainly cases that is real. Other times, I think that is a label for difficult patients. And the problem is that sets issues down the line, because once that's in the chart and once that's in the note, it is very, very challenging to find care. So I'm not saying that that's not a real entity. I'm just saying we need to be cautious when we're making a determination of CRPS, especially in the absence of an identifiable nerve injury.
Question for Dr. Grandizio. Could you go a little bit further into your indications for that dexamethasone and then Medrol dose pack? Is that all closed elbow injuries or any fracture about the elbow, or what specifically are you doing that for?
Absence of diabetes, pretty much all terrible triads or complex instability. I would say at this point, for things like distal humerus fractures, closed olecranon fractures, I'm a little bit more of a sometimes in that realm. I think in the back of my head, I'm still a little bit worried about bone healing, although I don't think that's well supported. But I would say all complex instability without diabetes, they're getting that steroid protocol.
What about capsulectomies?
Yes. Again, there's no great evidence for HO. And I would say conflicting evidence for NSAIDs. But I do think for like HO, excisions, and capsulectomy, I have found that very, very helpful.
I think the hallmark of steroid usage for me in the hand, not the elbow, is when you see people with stiffness outside their expected injury pattern. And we can call that whatever we want to call it, a flare, early CRPS, whatever entity you want to call that. That is a screaming indication for me that they probably need to be on God's anti-inflammatory, which is prednisone.
I think to your point too, I've been way more aggressive lately about doing carpal tunnel releases at the same time as distal radius fractures, and I don't think I've ever regretted it. And I've certainly had patients that have had this kind of issue afterward, where just like you're describing, and I wonder if I did a carpal tunnel release at the same time, would it have really changed it?
What's your criteria? I mean, do you have any, is it a gestalt or, I usually talk, do you have any prodromal symptoms before you broke your wrist? But I mean, you just see that pain out of proportion, or is it?
If it's prodromal, for sure. Like if they had numbness and tingling before, even if it's reduced and it gets better, I still will do it. And then I don't have a great way to quantify this, but if it's a really bad fracture, then I'll tend to do it. If it's more than 3 weeks, I'll do it every time, especially if it's shortened and you're re-lengthening it. It's the same thing as like distracting the nerve too much, I think.
That's a nice little study. That's really good.
There's a good study in JHS about doing carpal tunnel release for patients who have symptoms similar to CRPS, or what you would think would be concerning for CRPS, and that resolving a lot, even if they don't have any neurologic changes on their EMG. So something to look into. And then regards to your question, I think JSES had a big study about distal humerus fracture steroid protocol and the changes in motion that you referenced earlier.
All right. We're going to conclude with some closing remarks here, but I appreciate all the discussion, the case presentations, and the questions. So thank you. All right. So as we conclude here, there are certainly a lot of people to thank, and as we have a small token of appreciation for Dr. Agarwal and Dr. Ayalon from Geisinger, a little take-home souvenir. I was really hoping that we were going to be able to give you guys squallets, but the timing did not work out. So instead, we have a commemorative plaque. So thank you again. I think that we got to hear some things that we don't see on a day-to-day basis. I think it was really insightful. We can't thank you enough for being here and for being a part of this. So thanks again.
All right. And finally,
I don't need an introduction.
a man who needs no introduction, the chairman, Dr. Perenni, for some of our closing remarks.
Once again, I'm honored and humbled to be at this meeting. I give tremendous appreciation to Arturo and Nina for sponsoring this for the past 10, 12 years, I guess. As he mentioned earlier, it's been 20 years now since we first interacted, and I think I received more of a blessing to meet him than he did to have me as his physician, to be quite honest. It's been an incredible doctor-patient relationship. I want to thank our NYU guests. They've certainly provided us with incredible new knowledge. I just want the residents to know you can still do a good Perenni amputation and not have to go through all that expertise and looking for those nerves and whatever. I mean, if you're doing it at Geisinger with our patient population, with these severe diabetics, with tremendous wounds, and they're on death's doorstep. I mean, just get the amputation over with, and somehow they have some miraculous recovery. One can always reconsider doing something fancy, but our patients do remarkably well with a traditional prostheses. And although I did mention earlier that one of the last patients I saw at Geisinger before I retired had bilateral intraosseous prosthetics, and he said they were the best thing since sliced bread. They made him so functional, they felt like they were part of his limbs. He felt that they did not, they were not foreign to him. Somewhat similar to what Arturo was experiencing with totally insensate limbs that act as internal prosthetics. So it's really very, very interesting phenomena. So I think that's eye-opening. I mean, that's the wave of the future. And some of that fancy stuff in the hand, that just blows my mind. I mean, it's amazing to see the advances over the years. I've been at this now for 50 years, and some things are carved in stone, and don't forget that, while you learn some of this newer stuff. But there's still a lot of old textbooks out there that can teach you a lot. You don't have to read every journal and stay that far up to date and then forget about the ABCs of orthopedics. I want to thank Dr. Grandizio for moderating a tremendous educational experience. It's nice to see residents far exceed your capabilities or our capabilities over time. So I see Grandizio and Clenna. John Rich is here somewhere. Maybe, is he still here? John Rich was a resident many, many years ago. He actually looks older than I do, but I don't think that's true. But it goes back so far. Fred Hess is honored us here. He's, I think, the senior orthopod in our department right now, so he's taken over for me. So I want to say hello to Fred Hess as well. But again, thank you so much for attending, although I think it's a requirement. But despite that, we hope to do this as long as we can keep on breathing, and maybe, as Arturo said, maybe even after we've stopped breathing, this will continue. So once again, thank you for a tremendous morning. Very appreciative. Our new interim chairman, or whatever his title is, I don't know, but Dr. Murphy, thank you very much for the introductions as well. But let me mention my sister from Scranton joined us this morning. She has no idea what her little brother's been doing for the last 60 years. And so she finally got to see that it was a worthwhile profession. I think she wrote my cover letter to get into medical school, so I'm very grateful for that experience. Anyway, have a great day. Drive safely. Thank you.
2 quick announcements before we conclude. We're going to do some pictures immediately following this, and there are to-go lunches. Once again, I want to thank the Portacanskis for your continued support of our education, and looking forward to doing this again. So thank you, everybody, for attending.